Okay, all is well. So we can continue even as others join. So in the interest of time, we have barely 20 minutes to go for lunch. And so sorry about that. So sorry about that. I think it was not intended, but these things happen. Yeah, these things do happen. So let's continue with any questions that may be there for our friend, Dr. Lazarus Momanyi. All right. Oh, Henry is saying that we are still on music.
No, you can. From my end, I can hear you. I don't hear any music.
Who else is hearing the music? Clifford, are you hearing the music?
No, I'm not hearing any music. I think Henry just said something to let us know we are still on. I think
Eric.
he meant we put some music.
Oh yeah, Eric, could you just say that in French as well, the interpreter, so that those, I can only speak English. So if I say it in English, it's only the English speakers who will hear me. Eric, about the interpretation. From this mic. All right, so, okay, thank you. So for English speakers, please just click on interpretation. There's a button down there and choose on English. All right, so let's continue. Any question for Lazarus, or we let him off the hook? Okay. Now, usually in the science cafes, we usually get three voices: the voice of the journalist, the voice of the scientist, and the voice of the advocates. So I don't know whether Jackie Wamboe is able. Are you back, Jackie?
Yes, again, I'm here.
All right. So it's now your opportunity and time to speak to us. We've had the two speakers speak on various issues. We'd want to listen to you. Oh, you look beautiful. Hi.
Hello.
Hi. Yeah, so we want to hear from you. What is your take on all these things that the two experts have spoken about? And also, just if you have some other information that you want to pass to us about the topic of our discussion today, or anything that is going on in the world of HIV that you'd want the journalists, to capture and to know, maybe the latest research, latest development, any issue. I've given you a blank check, my dear. So over to you, Jackie.
Okay, thank you again for the opportunity. Let me introduce myself. My name is Jackie Waboi. I work for an organization known as AfroCAB Treatment Access Partnerships. AfroCAB is a network of HIV treatment advocates, and our organization focuses on the sensitization or information and also the advocating of optimal treatment. And we also deal with the sensitization and also information and awareness on advanced HIV disease and also diagnostics. I also work as a consultant for AVAC, where I am also advocating for the integration of SRH and HIV services. I am usually based in Nairobi, Kenya, but Agan woke me up at the ungodly hour of 3 a.m. in the morning. I'm speaking to you from New York City, where the sun is just coming up. So I had very, very interesting conversations and very lovely presentation for the two people who have spoken to us before. My colleague Patricia had a very excellent presentation as what's happening in the prevention landscape in Kenya. And also, of course, my friend at NASCOP, Dr. Momani, telling us about, you know, how the programs that are in place on the ministry side. So I just want to give my perspective as an advocate. I am HIV positive. I've been on medication for several years. So when you see me working in both areas of both treatment and prevention, I'm very passionate about them, especially because I was infected with HIV when I was a young woman, and the only option I had at that time.
Jackie, maybe you switch off your video so that we are losing you.
Oh, great. So I don't have to do that, right? So this is better?
Yes.
Okay, great. So do I pick up or do I need to go back? Should I just proceed again?
Start from you were infected, because that's where we lost you.
Okay, so I was infected with HIV as a young woman, and the only options I had at that time was either to abstain or to use the condom. And I didn't have the power at that time to be able to prevent myself. I didn't have the tools. I didn't have the ability to have the conversation about preventing myself from contracting any disease, even STIs. And that is how I got infected with HIV. And of course, now that led me to be a passionate advocate in terms of trying to ensure that young girls will not be able to get infected with HIV. And of course, that they'll have these prevention tools in front of them. And of course, on the treatment side, I've been passionate because I have been on treatment since the year 2006. I have had to take my pills every day. In the early days, it was twice a day, but now, luckily, because of the different treatment developments, we have now our treatment in one drug, although we are still taking 3 of those drugs in one tablet. So this is what has led me to be a passionate advocate in both arms. So now coming up to what has been presented before me, and I want to pick some of the things that I heard from Patricia's presentation. She talked about the vaginal ring, and she talked about how it is acceptable, it reduces risk, it creates choice, it is safe and effective, and it is also discreet. So like I mentioned, these options are not for me. I didn't have them when I was a young person, but these are the options now that are being provided to young girls. And I think it's something very exciting. I think it's something very, very useful, because this way now we'll be able to reach our targets, and we'll be able to reach the target of now trying to end AIDS by 2030, because we have these tools available for these young girls. And it's something that a young girl can be able to use when she's trying to negotiate for safe sex, because she has different options. And the options that she has are safe and effective. And then one of the most important things also, at least 2 important things, is that it's acceptable. It's something that can be used. And of course, that it is discreet. You will know that young people like to be discreet, whenever they are indulging in sex. And if you give them a method that works the same way, it is something that they'll be able to pick up and to use. She also mentioned the different other new prevention technologies that are coming up, like the FTAF, the different long-acting injectables. Again, something also very exciting, because when you want to prevent something, it's important that it comes out in a way that you'll be able to use it regularly. Otherwise, if you don't use it regularly, it won't work. So if we have something that is long-acting, that will stay in your body, that you only have to administer it for a very few times, it is also something very, very exciting. So these are the things now, as HIV advocates, we look at. These are the things that we're excited about. And these are the things now that we are also advocating that we get them, and that they are accessible and reachable to our communities, especially in the rural areas, or in the areas where we know that there is high HIV risk, and also something that will be able to be accessed by different populations. We have the sex workers, we have the the men who have sex with men. We have, also the female sex workers and stuff like that. So those are the population that we think of, and those are the population that we also want to be able to access these products, and especially young girls and women. So when we hear that these methods are available, that the research is going on, we follow this very closely just to ensure that, one, the community is informed about these products, so that by the time they are being rolled out, the community is aware and they'll be able to pick them up very fast. We're also excited because we have the opportunity to, like I mentioned, to follow the research, to point out some of the things that we feel may not be friendly to use. Some of the methods sometimes may not be friendly to use, and as advocates, we have the opportunity to give our opinion about that. And then on the issues of accessibility and whether these products now would be able to be affordable especially for young girls. These are the things that we also look at when you're introducing something like a prevention product that is long acting, and is it available? Will the young girl be able to afford it? Will she be able to even tell her peers about it, so that amongst now that community, the young girls will be able to access this product and they'll be able to prevent HIV amongst themselves. Those are the things that we look at. So like I say, we're very excited about this. We're watching very closely. We also have the opportunity, like I said, to inform young girls around our communities about this product. And so we also have the opportunity to sensitize them enough to create demand for these products, so that by the time they are being rolled out and by the time they appear in our guidelines, young girls can be able to go to the facilities and actually request for these products, because they know these are products that are going to help them to prevent HIV. And like I said, they'll be able to have the conversation of negotiating for safe sex with their partners. So in terms of now what my colleague, Dr. Mamani has said, he's given a very good landscape as to how the ministry has, provided all these different treatment and different prevention methods for our communities. Working very well, again, I know, with communities involving us in the issues of looking at the guidelines, getting our opinions of as people living with HIV, is this the treatment we want? Is this the kind of treatment that we feel is useful for us? We were, of course, again, very much involved. We are very much involved with this guidelines process, and we encourage the ministry to continue giving us the opportunity to give our opinions as people living with HIV, because I always say, he who feels it knows it. And when we have these opportunities, again, we also request that, like I mentioned earlier, that these methods are available to our communities. So sometimes if we have issues that maybe the research would show that maybe this drug is not appropriate for a certain population at this time, it's important to let the community give their opinion about that first before denying people these treatments and also these prevention methods. We're also excited that we can inform people about the optimal treatment, how treatment has become easier to take. Like I mentioned, well, in the early years, we were taking our drugs twice a day. Now we're taking it once a day in one tablet. And the drugs are less toxic. The drugs are easier to tolerate. We are able to adhere more because the drug doesn't affect us so much. We have less side effects, and of course our viral load is being able to stay suppressed. And of course, now leading to root cause, like Dr. Mamani mentioned, we are able to keep the virus within ourselves and not to spread it, as they say. So we are very appreciative of these things and the way that we are collaborating with our ministries and trying to have this conversation so that we will be able to reach our targets and to end AIDS by by 2030. Thanks again. That's all I have. I hope it is sufficient, and I'm ready to take any questions.
Okay, thanks. Thank you, Jackie. And sorry for making me look so bad that I'm the one who wakes you up when you're enjoying a good place like being in the US. Some of us just dream of going there. So I will never wake you up again, but I'll try to make sure that when I need you, I get you. Now, Jackie, I just want to ask you, what are some of the things that you really think need to be improved on in terms of, because we are seeing a lot of preventive approaches and a lot of tools that are being brought on board. That is one. And two, what do you think it is that us journalists are not capturing that the advocates would really need us to capture more? And three, how do you see, where do you see HIV AIDS, in terms of infections in the next 5 years?
Okay, so some of the things we like to see is more and more sensitization onto trying to make HIV look like a normal condition, not putting HIV in this box of this killer deadly disease, this horrible virus, or this, because we live normal lives. Like I mentioned, we are on treatment. We are on treatment now that is better. We are able to work the way, like normal people. We are living very productive lives. So these are the kind of things these are the stories that we like to see coming out. That HIV people are just ordinary people. Just remind me on the second question, please, again.
Where do you see HIV in the next 5 years?
So before I answer that, also, I know Mesha does very good work on sensitizing journalists on the science. So the reporting will go on the science side. But what about the reporting on these people now who are taking these products? Like for me, what has this optimal treatment done to somebody like Jackie? What has optimal treatment done to somebody like a young woman, maybe somewhere in Sub-Saharan Africa? And also now, when you follow the science about these different HIV products, what are the stories of these people who have been taking oral PrEP? What is the story of these people who have been, like when we get into now the long-acting injections, we want to hear those kind of stories. What are these kind of interventions doing to people? How is it transforming their lives? So those are the kind of things that we like to see coming up in stories. I know HIV is a story that has been said like for the last over 30 years or so, but it is not a story that should be put aside. It's not a story that should not stop being talked about, because we have not yet reached the cure that we want to, just like Dr. Mamani mentioned. And the more we talk about it, the easier it will be for people to prevent themselves from getting HIV. Because as much as we say it is a condition that we can live with, it is not a condition that you would want everybody to have, because again, it is not an easy road to take medication every day. That, and I will tell you, that is why we are excited now that we have these long-acting products, and we'll be able to, to administer these drugs less and less, in lesser frequency into our bodies. So I just want to say that the story is not tired. Don't get tired of telling the story. Look at the positive side. Talk about how the science is now transforming our lives. And I think that way you'll be able to reach ending AIDS in 2030 much faster. So in the next 5 years, I see a world where I don't have to take a tablet every day. I don't have to visit my facility ever so often, even though now we appreciate the fact that now we have multi-month dispensing, where we have our treatment now. Our frequency to the clinic now is like up to 3 to 6 months or even 9 months. But all the same, if I lived in a world where I didn't have to actually see my service provider but still be able to take my treatment, I think that would be the perfect world for me. Like in the next 5 years. And just as the analysis that Dr. Momanyi has given us now leading to the cure, I see ourselves approaching that cure like much faster than I did like about 10 years ago. So that would be my take.
You don't see a world free of HIV/AIDS in the next 5 years?
I said towards the cure, we're reaching there faster, much faster than I did like 10 years ago.
Yeah, because if Kenya now we are talking about 94%, you know, or 98% on DTG, 94% on, I mean, so basically means that this small number of 4%, and then now you have allowed us to go to the field without boots, because you've been told that U is equal to U, makes it happen. Dr. Lazarus, I hope I'm not spreading rumors, but U is equal to U makes it happen. And that basically means that I don't need to fear Jackie because she's HIV positive. If I want to have sex with her, I can do so without fear of any controversy or something like that, because she will not infect me with the HIV. Am I thinking too much? Am I getting too excited about this, Lazarus and Jackie?
I'll let Jackie go first. Jackie,
Dr. Momanyi, I think you know what I'm going to say. Prevention goes both ways. Don't leave prevention to the person who is infected. Protect yourself.
Yeah, I agree with Jackie. So I think, again, that's a message. I mean, as we pass out this messaging also, we are passing it out of the social responsibility. We are still promoting all the other combination prevention strategies, as we said, usually because it does not protect against STIs and so on. So we are careful not to say that now it's let the games begin. That's not what you are saying.
I was almost saying that we are so proud of our scientists because, one, our scientists have worked so hard to ensure that we have paralyzed what we call COVID-19. And now our scientists are also working very hard to ensure that a gun can enjoy sex without thinking about condoms, without thinking about all these other things. And that is the excitement that I have today. And that is my takeaway from this conference. But there's something else that I want Jackie to talk to me about. We are talking to an African audience. Okay. Yes. I do not know, because Kenya might have been hit so hard by HIV. We seem to be, be ahead on many of these things, be it treatment, be it prevention, be it what we call what. In the morning, we were told about the 4 countries that, are taking a lead on the Vaginal Ring and that kind of thing. How is Africa faring on in comparison to Kenya?
In terms of, okay, you see, that's an interesting question. Again, I would say other countries are also picking up quite fast, because the way us advocates work, we like to network, like not in silos. We like to network across the board. So we have these conversations with other advocates like all over Africa. So most times, some of the advocacy that we do in trying to create this awareness, like I was talking about, the sensitization, we're doing it all over Africa. So I'll say other countries are also picking up and following suit. But then again, remember I don't know what the word is, because maybe Dr. Momanyi can help me with this technical word, because sometimes I forget. We have different rates of HIV infection across the board in different parts of Africa. So you may see that some countries may be doing much better because they are working harder to work on this because of their rates of infection are higher. And some of them may not be working as hard because they don't have as much incidences as we do. But that does not mean that we should ignore the effort, and that doesn't mean that we should slow anything down. We should continue to do these efforts collectively, and then soon, like you say, we will have the end of AIDS by 2030.
I think we want to wind up this session, which has been very lively, notwithstanding the fact that we had a technical problem. We lost about 26 guys, not to an accident, but I'm very sure they are trying very much to come back to the conversation. But at a 72 and we were doing 98, that basically means we've lost about 26 guys. We are very sorry about that. But in the afternoon, I think it will be bigger and better, and the conversations are getting hotter. So that basically means that you have chosen, you've made a right choice for attending this conference, even though I know that all of us would have liked to have had it, as an in-person conference. But we are working hard on that with our funders. We hope that you will go out there and even do self-fundraising to ensure that we have a wonderful conference in the coming year. If there is no question, because I'm not seeing any on the chat, or the chat was disabled, I would want to end here. But if you have anything to say, please raise your hand very, very quickly. Raise up your hand very quickly so that we can end the morning session. Okay, I'm not seeing any hand up, so that basically means that we are okay. And Jackie, you are lucky nobody is asking you for your contacts. So basically that means that they'll come through me, and you see that makes me look more important.
You can
Yes.
take the glory now, man.
Yes. So thank you, Jackie, so much for your presentation and for talking to us from wherever you are. And okay, and then I'm being asked to share the recording or what have you that we will get. I want to say that we accept stories, and the stories will be published today. Definitely we give something back for the ink. So please send all your stories to Science Magazine, Sciencey Magazine. Could somebody just type that for me in the chat box? Sciencey Magazine at gmail.com. Sciencey at gmail.com. Please send your article, because we are going to design them today and then publish them today, and by evening or before you go to bed at around 10 o'clock, we'd have circulated them to all of you. With those few remarks, I want to say that we welcome you for the afternoon session that begins at 2 o'clock on the dot. And you know what we are going to talk about. We're going to talk about the issues of antimicrobial resistance in Africa. And we're also going to talk about I think 2 other things about the leishmaniasis. I hope I've pronounced it rightly. And then we're also going to look at WASH. People have been talking about WASH and then COVID-19. We want to look at the poo, what is the hullabaloo about the poo and that kind of stuff. So ladies and gentlemen, take a break. Enjoy yourself, enjoy your meal wherever you are. I hope that God is going to provide that for you. If we're in a conference, we would have provided it, but I know that you're working from the comforts of your home and offices. Enjoy your lunch, and let's all come back by 1:45 2 o'clock Kenyan time. The interpretation continues in the afternoon. So can you just congratulate yourself for surviving the morning? Thank you all. We are not going to end the call here. It will just continue. You can log out if you want, but then log back, or you can stay on call until that time that the next session begins. So thank you all, and see you again in the next 1 hour. Bye-bye. So good afternoon, everyone. Please choose your interpretation. Click on the interpreter and then choose the language that you want. If you are English, take English. If you are French, take French. I'm just testing the mics of two people. That is our moderator for this afternoon, Christophe Itayezu from Rwanda. Christophe, are you already on the call?
Yes, Captain. I'm
Right.
ready. Yeah, I think I think you can hear me clearly.
Yeah, I hear you clearly. Thank you. I was just testing your mic. Huh?
Great.
All right. Are you going to use French or you are going to use English?
English, please.
You will do English.
Yes, please.
Okay, thank you. Now, Evelyn is our first presenter this afternoon. So, Evelyn, I just want to test your mic.
Good afternoon, everyone. I hope you can hear me clearly.
Oh, yes, we do hear you clearly. Will you use
Good,
English or French, Evelyn?
I'll speak in English. Thank you.
You speak in English. Thank you so much. Right. So, I think we are almost starting. Maybe we give people just about 3 minutes. We start at 2 minutes past 2. I think that would be good enough. So, Christophe, I will not speak to you again until the end of Evelyn's presentation. So, 2 minutes past the hour, you are free to start navigating.
Yeah, sure. Please give me more 2 minutes up to 5, just to
Right, take it up to 5 minutes, but please manage the time.
Advice.
Yeah, because we need to finish by latest 5:30 for this session. So over to you. Hello, Kemo. Kemo, how are you doing?
I'm struggling. I just realized I can hear you now.
Oh, you can now hear me. You are also very clear today more than ever before.
Thank you.
How is Sierra Leone?
Yeah, Sierra Leone is okay. I just woke up from sleep and I saw the message that it started. I said, let me check in. Yeah, so I'm here now.
Yeah, so welcome. We say karibu sana.
Yeah, thank you.
All right. Yeah. Okay. So you missed the morning session. That is up to you. We will see how to punish you for missing the morning session.
Too bad.
Too bad, but we'll see how to compensate that time. We'll send you the presentations and the recording.
Okay.
Yeah. Okay.
So the next session is starting when?
The next session is beginning right away. Actually, the next 3 minutes, and I can see. Yeah, I can see our moderator is ready. Maybe I just test for you. Kemo, you can switch off your, what do you call it, video and mute yourself. Can I also just test the interpreters? Are we okay? Are we good to go? Thank you. At the flight desk, I think everything is okay there. You seem to be enjoying Branley. Thank you. Thank you. Okay, that's nice to hear. Okay, so you'll not hear much from me. You'll just be hearing from a guy called Christoph. So Christoph is going to be our captain this afternoon, and John is sitting on the desk for the technical matters. Yeah. So in any case, something crops up, just send him a WhatsApp message. Okay.
Yeah, thank you. Thank you so much, Aga and Daniel. We are starting shortly. I think we are going to start with the session where we have Dr. Evelyn Wesangula, the coordinator and the coordinator of Antimicrobial Resistance at the Ministry of Health, and Mr. Kariuki Mugo, the country manager, water and sanitation for urban poor. Dr. Evelyn, I think you're ready. Can you hear me?
Yes, I can hear you. I hope you can hear me clearly.
Clearly, great. Mr. Mugo, can you hear me?
Yes, Christoph, I can hear you. Thank you.
Fantastic, fantastic.
Christoph, we can't hear you.
Yes, I was not speaking. Thank you, everyone. I was trying to download the file from Mr. Mugo. Please, Captain, you can forward it to me. It's not opening correctly. That's what I was struggling to download on my on the device that I have shifted to.
Okay, so just let Dr. Evelyn, start, and then we'll sort out the issue of Mr. Mugo.
Okay, sure.
Mr.
Thank
Mugo,
you.
yeah, and Mr. Mugo, we
Yeah.
are sorry about your title. We know that there's a change. We got your title wrongly. We will correct it when you're making the presentation.
Thank you. No worries.
Sure,
Thank you.
Okay, thank you for collecting that again. Yeah, we have Dr. Evelyn Wesangula. He is a pharmacist with Masters of Science in Tropical and Infectious Diseases, heading the Patient Safety Division at the Ministry of Health in Kenya, who has successfully championed the development of the National Policy and Action Plan and accompanying strategies for antimicrobial resistance in Kenya from a multi-sector perspective. Dr. Evelyn, if you can hear me, the floor is yours, but I'm reminding our guests, everyone on the call, that we have a live translation, the interpretation in French. You can see the globe sign at the bottom. You can switch to French if you are comfortable with French, or switch to original audio if you want to hear directly from the main room. If you want to make this session as interactive as possible, please follow the presenter so that you note your questions and interventions. You have time to contribute to this conversation. Thank you. Dr. Evelyn, the floor is yours. Thank you.
Okay, thank you very much, Christoph, for that kind introduction. And I also want to appreciate the invitation that was extended to me by Mesha. I will start my presentation, and I will also request just to switch off my video so that we have enough time to be able to just go through the presentation without unnecessary interruption. Would you please confirm if you can see my screen?
Oh, very clearly, can see it.
Okay, thank you very much. So I will start my presentation, and my topic for discussion this afternoon is antimicrobial resistance, and just looking at some of the key interventions in Africa. And to start us off, just a brief background on what about antimicrobials and what they are and what resistance is. And today we are discussing this because we know that antimicrobials have actually played a critical role in saving lives in humans. If it was not for saving lives, we would not talk about it being a public health threat. And it's not just about the use in humans, but also the aspect about the use of antimicrobial agents in agriculture, mainly in animal production. And when we talk about that, we have found that antimicrobial agents are used for both therapeutic and non-therapeutic purposes. That means for treatment, and also purposes that are not for treatment, maybe for prevention of infections and to some extent growth promotion. So because of the increasing levels of resistance that we are seeing across the world, their effectiveness is compromised. And when effectiveness of any medicine is compromised, then the standard treatments that have been prescribed eventually become ineffective. And what that means is that infections continue to persist, and these infections may spread to others, and in some instances can also result in death. And looking at the period where during which antibiotics were discovered, and Alexander Fleming being the one who discovered penicillin, one of the earliest antibiotics that we have used for so many years to treat simple infections that can also be life-threatening if effective therapies are not available. What Alexander Fleming did and what he actually predicted, and the reason why we are in this discussion today is because of what he said in 1945 as he received his Nobel Prize. And he said that it is not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations that are not sufficient to kill them. And he says that there is a danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drug, make them resistant. And as you read through this quote by Alexander Fleming, I believe that you can begin to picture why we are talking about this and the danger that you have all maybe contributed to, and the threat that is actually faced, and the danger that is faced by all of us because of our actions, either knowingly or unknowingly. We have gotten to this level where now the microbes have actually become resistant to the drugs that have been developed over time. So we look at what drives AMR. For example, we have the human interface, we have an animal interface, and we also have the environmental aspect. So we are looking at either misuse or overuse. So misuse, you probably don't need an antibiotic, and I'll give an example of how we have misused antibiotics during the COVID-19 pandemic response. And one very famous antibiotic that was used by almost everyone who suspected that they had COVID was azithromycin. Before that, we didn't know. But what we know is that antibiotics are only active against a bacterial infection and not a viral infection. So that's a component of misuse. Then you have the component of overuse. You actually go beyond what you are supposed to use, and in some essence, you can either take an overdose, or even in the event of use of these antimicrobial agents in animal production. And also we are seeing the environmental contamination through effluent and waste that comes from different sectors, such as the pharmaceutical industries or even our hospital setups. Then we also have the place of healthcare transmission. What happens within a healthcare setting when infection prevention and control measures are not put in place? And you find that a resistant bug or a resistant microorganism can actually be transmitted either from the patient to the healthcare worker, or from the healthcare worker to the patient. That's very possible within a healthcare setup. Then you have the place of suboptimal diagnostics. If we do not have well-equipped healthcare settings to be able to give the correct diagnosis, then what are the chances of getting a right prescription? That's a question you would ask at the end of the day. And then the place of vaccine coverage. When you have a high vaccine coverage, then that means that the chances of infections will also be minimized. And of course, because of lack of knowledge in some instances, you have suboptimal dosing. And even if you have the right piece of information and you have poor quality antimicrobial agents or poor quality drugs, if they are substandard, or they actually probably don't contain the active ingredient, then that is a danger to the population that is affected by that. And of course, we now know that infections can travel, and if an infection can travel from one part of the world to the other, so can a multi-drug resistant organism. All it needs is a carrier. It could be a person, it could be an object, and that will actually be able to transmit a multi-drug resistant organism from one point to another. Then we have the place of mass drug administration for human health. Because of our period of time, if we have a mass drug administration, then that specific population becomes exposed to that particular antimicrobial agent for a long period of time. And that can actually cause the emergence of a strain of microorganisms that is actually resistant to that drug that has been administered over a long period of time. So when it comes to antimicrobial resistance, we talk about the One Health approach. So what this means is that because of the complexity that is brought about by the different drivers for AMR, there isn't any single sector that can successfully contain antimicrobial resistance. So those that are in human health must be able to take their responsibility. Same to those that are in the agricultural sector, the livestock production sector, the aquaculture sector, and also the environment, to try and understand what is it that is circulating within our environment as a result of either contamination from industry or even just sewage water or any water supplies. And once these transmission dynamics are well understood, then we are able to take the necessary interventions. So this is a fairly busy slide, but it just tries to paint the situation. What's the reality? And this is actually drawn from a report that was launched this year in January, and it was published in the Lancet, what we call the GRAM report, and that's the global burden of bacterial antimicrobial resistance. And what came out clearly is that young children were at significant risk compared to other age groups. And you can see from the report, we are able to note that 1 in 5 deaths that occurred due to AMR occurred in children who are under 5. And these occurred from previously treatable infections like simple pneumonia, for example. The other reality we are facing because AMR is that we have over 1 million people dying each year due to infections like lower respiratory tract infections or bloodstream infections or infections that occur in the abdomen, because the bacteria that are causing these infections have become resistant to treatment. And the other piece of information that has come out has actually picked about 5 leading bacteria that are actually attributed to the leading causes of death. And you're going to see later on why these priority pathogens were picked and how that impacts on our health. So what we also know now, as much as antimicrobial resistance is not a new phenomenon, if Alexander Fleming talked about this in 1945, this is 2022. But what has come out clearly is that we are not innovating fast enough to have effective vaccines and even antibiotics or medicines. The microbes have actually outpaced the human beings. The other bit also that requires our urgent attention is that out of the 7 deadliest AMR bacteria that we violated, there's only 2 of these bacteria that actually have a vaccine. So what that means is the others cannot be prevented by vaccines, and we must find other ways of preventing infections from these microorganisms and even finding suitable treatments or effective treatments for this. The other bit that is urgent and also for us to note is the place of the hospitals, and knowing that many hospitals, because of these pathogens, most of which are found in hospitals, are struggling to keep their patients safe. And this burden, because of antimicrobial resistance, has increased the risk of death because of hospital-acquired infections, which need us to put into place very robust infection prevention and control measures. And it's not just about the deaths, but the cost of care. And some of the case studies that we have had have even indicated that patients have had to spend up to $10,000 US per week for a course of treatment of a last resort antibiotic. And the question is, within our populations, how many of our patients would be able to afford such a prescription? So the relevance is more now than ever, because now we have data and we are able to even quantify this in terms of death. And we're also looking at the opportunity to support or even strengthen our response from different perspectives. And of course, what we know is that antimicrobial resistance is actually preventable. If you're able to take action, if you're able to support or increase our support for infection prevention and control, increase access to vaccines and basic things like clean water and sanitation. And I'm really glad that the talk after mine is going to be based on water, sanitation and hygiene, very central, even in the reduction of the spread of antimicrobial resistance. And again, for us to be able to go back to our communities, which we influence in a big way, to be and to encourage them and actually just spread the word that people need to be more thoughtful about the use of antibiotics within their communities. And of course, also advocate for funding for countries to be able to take the necessary action. You can see this is more data from the Graham report. You can access it, it's available online. And you can see we are talking about 1 million deaths. And the new evidence is that AMR is now a leading cause of death globally. It's higher than HIV, AIDS, and malaria. But why are people not talking about it? HIV has received a lot of advocacy. There's a voice, there's a face to it. But unfortunately, antimicrobial resistance doesn't present the way HIV, malaria, and TB have presented themselves in the past. So it becomes hard to frame this agenda. It becomes hard to put a face to this agenda. So you can see in Sub-Saharan Africa, the number of deaths that have been attributable to resistance, 255,000 in a year. Look at the under 5 deaths just attributed to AMR. And of course, looking at the leading pathogens like Klebsiella, pneumonia, which for us, we refer to it as a gram-negative bacteria, very difficult to treat, and strep pneumo. So once we know the kind of microorganisms we are dealing with, then it becomes easy to contain. So I focused on Sub-Saharan Africa, but you can see what the statistics look like for the rest of the world. So we've talked about that, and what we know now is that we need urgent action, and it requires urgent action not just from one part of the society, but we are saying all the players must put their efforts together to avoid further preventable deaths. And when you look at it, I've already talked about the number of deaths that in 2019 alone that were caused by AMR. And by the time a patient dies and they've gone into a healthcare facility and the doctor says, I have no more options for you. And that is where we are. By the time patients are dying because of antimicrobial resistance, it means that clinicians have been left powerless against common infections. And if we don't take action now, then in the coming years, the number of deaths is going to increase because antimicrobial resistance is not going to be, in terms of spread or emergence, will not be reduced because of the lack of action, and not just action, but urgent action. So what you're saying is that right now, AMR is threatening healthcare systems. I've talked about the cost in terms of treatment. So mobility and mortality is a big factor here. And if you look at Sub-Saharan Africa, you're looking at the number of deaths per 100,000 people. And we have about 24 people for every 100,000 dying because of AMR in Sub-Saharan Africa. These are just some advocates and some champions that have worked on antimicrobial resistance in Africa. And I think what we want to emphasize today for all of us to take home is that Sub-Saharan Africa has the highest burden of AMR globally. And when you look at your health systems in the different countries that you represent here today, how would you gauge them? Why do we have the highest burden? If you look at our systems in terms of laboratory capacity or diagnostics, we have challenges. Access to medicines, look at poverty, access to clean water, sanitation and hygiene is a challenge. And because all these are underlying factors, then of course we will bear the highest burden of AMR. But unfortunately, as we bear the burden of AMR, the highest burden of AMR, the development of new antibiotics will not favor us. This will come with a cost. And because of poverty, many patients will not be able to afford the newer treatments. And as a result, there'll be increased mortality due to antimicrobial resistance. And this is just a timeline looking at antibiotic development. And what we now know is that pharmaceutical companies are no longer interested in developing antibiotics, because the sooner you develop an antibiotic, within a very short period of time, we are already recording resistance. So in terms of returns on investment, antibiotics do not present the best bit in terms of assuring an investor on their returns. So we have noted from the report that we have leading pathogens, and actually 4 of these 6 pathogens that have been identified are what we call gram negatives, which have a significant contribution to the burden of disease and limited treatment options in any population. So it's just good for us to note that as well. So where are we in terms of responding to this threat, which we call our silent pandemic? Of course, through the tripartite, and now it's a quadripartite, because the United Nations Environmental Program has also joined the tripartite. We are able to monitor country progress every year through what we call the tripartite AMR country self-assessment. Every country that is implementing actions against antimicrobial resistance participates in this. And we can see, because of the pandemic, the response rate for this reporting period, 2019-2020, was lower than the previous years. And we have about 136 countries globally out of the 194 member states responding to this, compared to 159. So a slight drop, and we understand a lot of our efforts also were geared towards the COVID-19 pandemic response, and a lot of other healthcare issues kind of fell by the way. And we can note that actually countries are now moving forward on key actions to help address antimicrobial resistance. Compared to the previous years, we are seeing an increase in the number of countries that now have what we call the national action plans. So countries drew their national action plans on antimicrobial resistance from what we call the Global Action Plan for Antimicrobial Resistance, which was launched in 2015 by the tripartite then. And countries were given about 2 years to develop their own action plans that were context specific and begin to implement this. So we have noted that countries also now have, a few countries have functional multi-sectoral working groups. Like I said, there isn't any single sector that can address this problem on its own. And some countries, and you can see just a few, about 27%, have a national action plan with funding identified and being implemented. Because without funding, even if you developed an action plan, it would not be effective. So we've seen that if you look at the trends over time between 2017 and 2020, we can see an increase in terms of the countries that have developed their NAPs and are now receiving funding up to about 93%. And you can see for this other graph on my right, you have countries that have developed their national action plan. For example, in 2017-2018, we had 93 countries with NAPs, but only 19 of those 93 countries reported that they had a funded national action plan. So without funding, definitely there's no implementation of any intervention that's going to take place. And this number has increased over time. But I wish in 2019-2020, we were saying 100 countries have their action plans funded. And I think that's a question that we can ask ourselves even as we begin to think about what extra thing can the media or the journalists do to catalyze funding for the implementation of the national action plans that have been developed. When we narrow down to Africa, you can see the progress that is marked there, and the colors are shaded, and you can see the key there. If it's a red, that country does not have an action plan. And I think our aim is to have all countries with a funded action plan. Remember what we said about travel and the transmission or the spread of antimicrobial resistance. If your neighboring country does not have an action plan, then your country is in trouble, because we have a lot of cross-border activities, and we saw what the COVID pandemic revealed to us, that the world is actually a village. So if your neighbor is not taking action, then you are affected as well. In terms of implementation, you can see implementation is being tracked across the different sectors. A lot of activity in human health, animal health, you can see plant health, very little compared to what human health and animal health is doing. So what this specific graph just shows is that a lot of our interventions are in human health, animal health, followed by food safety. But when you look at the environment and plant health, we hope that their actions can also match what is being done in human and animal health. And what we've realized a lot of times, many of these sectors don't participate or contribute effectively because they don't understand the burden of AMR within those specific areas. And of course, the other place is awareness in terms of having a plan and having countrywide coverage. A lot of this impacted on by funding. So these are just examples of what we've done as a country. We've been able to hold the World Antimicrobial Awareness Week for about 7 consecutive years, but we are not yet where we are supposed to be. We still have a long way to go. And we just need to address several target audiences, the students, you need the farmers, you need the patients, you need the whole community to be educated as well. So we also bring in the student community, and we encourage the formation of One Health clubs right from college, so that as these students graduate into practice, they already understand the kind of public health issues that are there in their communities, and they're able to work in a multidisciplinary team. The other big is surveillance, which was critical. At the beginning of the implementation of national action plans, a lot of our countries didn't have data because they didn't have surveillance systems in place. But you can see over the last 3 or so periods of reporting, there's been an increase in terms of national AMR surveillance activities, which is a positive thing, which means then that countries now begin to have data. The other challenge we've had is the regulation on antimicrobial sale and use. And do countries actually have a monitoring system for sale? Countries have regulations. You can see on the bar graph here, you have countries that have regulation, but even fewer countries are actually monitoring the sale and use of antibiotics. So we have challenges when it comes to the enforcement of antimicrobial sale and use. The next area of intervention is infection prevention and control. And this was actually taken from the self-assessment report. And if you look at Africa, very few greens. When you don't see a green, that means you don't have a very robust national program on infection control. A lot of yellows, meaning they have a program, yes, but in terms of implementation, there are still challenges. And over the last 2 years, we've seen a boost in infection prevention and control and WASH in all our countries because of the response to the COVID-19 cornerstones of cutting or stopping the chain of transmission. That is why people are being told to wash their hands. People had to wear masks. People had to sanitize. We had to social distance. All these were actually infection prevention and control and WASH measures. And if we can sustain that, we are definitely going to see a reduction in the transmission of multi-drug resistant organisms. So we also looked at countries that actually meet minimum requirements for infection prevention and control. I'm dwelling on IPC because I know it's one of those cost-effective interventions that can be taken up by any government and any institution and will have great impact on patient outcomes in terms of the reduction in infections and also limiting the emergence and spread of antimicrobial resistance. So it looks at the IPC program, whether it's existing, do countries have guidelines and training? Are they tracking hospital-acquired infections, for example? Are they monitoring their practices? How is the workload? The other bit is a human say that antimicrobial resistance has to be treated like a health system issue if you're in the health sector, so that you're not just addressing one pillar, but you're looking at all the building blocks of a health system, from financing to human resource to medicines and medical devices and technology. We need to look at all these components. And of course, one of our weakest areas, especially in Africa, is our built environment. Are our facilities built to the right standard so that even if you propose a guideline, it can actually be implemented? So of course, the other bit, I've already talked about data, and of course, the quality of data has been a challenge, but over the last couple of years, through several development partners, a lot of our countries have continued to improve the quality of data so that it can guide the treatment options that are being taken and also guide policy decisions. Several efforts apart from infection prevention and control. I've talked about awareness. I've talked about surveillance and research. I've talked about IPC. And now I want to go into what we call antimicrobial stewardship or optimizing the use of antimicrobial agents. And if you look at WHO's report, to date, we have about 40 African countries that have a national action plan in place. This is good news because that means that for each of these 40 countries, these conversations are already happening. But now what needs to be emphasized on is the implementation of the recommendations that are in the national action plan. So for antimicrobial stewardship, this simply talks about proper use of antimicrobial agents. And there needs to be commitment, and we say this commitment must come from leadership. Is leadership willing to fund or to support the actions? Because some of the actions will be harsh. And I'll give an example, like a certain level of antibiotics can only be prescribed by a certain level of clinicians. Not everyone will have a right to prescribe the last resort antibiotics, for example. So if we don't have commitment from leadership, then that particular aspect will be challenged. And of course, tracking what we are consuming and using and reporting this for purposes of learning and making decisions. And of course, building capacity through education and giving our healthcare providers the right levels of information and knowledge that they require. So I already talked about the systems level approach, incorporating stewardship components into accreditation standards and quality measurements. And this is not just in human health, but also in animal health. What kind of products, animal products, do you want to see What kind of plant products do you want to see? What are some of those environmental standards that we want to put in place? So these have to be addressed within a national level antimicrobial stewardship strategy. And of course, we need to mobilize resources and have this are being implemented at the lowest level. If it is a healthcare setting, even that dispensary that has one nurse must be able to implement some antimicrobial stewardship components to make sure that their clients are safe. So the question that we've asked ourselves, will this really work in our low and middle income countries? And many people argue that we are resource constrained, but that shouldn't be an excuse for us not to be able to implement the interventions. Even in a resource constrained environment, we can still optimize how we use our antimicrobial agents with the right knowledge, both in the community and in the practice settings. Antimicrobial stewardship is possible to implement. And definitely when we implement stewardship interventions, there'll be demonstrable cost savings. A lot of our leaders want to invest if they can be assured that there's going to be a saving. And there'll be a saving because studies have indicated and shown that 50% of all antibiotic prescriptions are actually inappropriate. So if I'm spending $2 million on antibiotics every year, and 50% of my prescriptions are inappropriate, if I bring in an intervention to ensure that my use is appropriate, I'll be able to save $1 million every year. So that's a direct demonstration of the importance and the impact of antimicrobial stewardship programs. There are challenges, of course, in terms of implementation. It is not easy in our setup. Sometimes you lack the policies and the framework on optimizing use, both in human and animal health. Sometimes we have the lack of professional and institutional commitments. We know that antibiotics are prescription-only medicines. So at a professional level, what binds me to be able to prescribe ethically? And sometimes you have weak governance structures, and all these are at a national or an institutional level. And sometimes when you don't have updated treatment guidelines, it also becomes a problem. Diagnostics are a big challenge. And if you just look back into your healthcare facilities, how equipped are the laboratories that you interact with, for example? If we have limited capacity to detect antimicrobial resistance, then even the prescription is going to be a problem. The quality is also a challenge. Continuous availability of consumables. You can have a well-equipped lab, but if you don't have supplies in constant, in terms of availability, then that doesn't help your process of collecting data for decision-making. Infrastructural challenges like the lack of water. I know Mugo probably will address some of this as he talks about WASH. The lack of electricity, proper waste disposal, all these are challenges that will hinder implementation of antimicrobial resistance interventions. And of course, the outcomes will be affected thereafter. And the other bit is with reference to the access to quality assured microbials. Sure are we that whatever is out there in the market is actually of good quality. But a lot of our national medicines regulatory authorities have put in place post-market surveillance to ensure that what is presented before a drug is registered and licensed for sale in the market, actually the quality is maintained throughout the period within which it is valid. So we've had successes of antimicrobial stewardship in Africa, where some hospitals in countries like South Africa have been able to sustain a reduction in antibiotics. If possible, we can be able to do this and actually succeed in a different setup. And you can see these are different countries that have had antimicrobial stewardship interventions and just conversations about AMR. This is Sierra Leone, this is Kenya, a lot of engagement, multiple stakeholders across different setups. This is Tanzania, so you can see this conversation is happening everywhere. This is Zambia, so we are, different countries are actually taking action, and we say that it doesn't matter as long as you're making a step towards the right direction. That is what is important. This is still Zambia, and you can see guidelines are being launched, and this is what we need to make a difference in terms of what we want to see at the patient level. Now that I'm actually speaking to journalists in the media sector, we know you have a unique responsibility to the reader, and we can't compare scientific reporters to those that are reporting sports. Your responsibility to the reader or the listener is so heavy because what you say is taken up by the population. Of course, we bank on you to understand the science and be able to translate this accurately to the people the millions of people who listen to you every day. And of course, trying to balance commercial interest versus public interest. And this being a public health issue, just the way we dedicatedly covered the COVID-19 pandemic, we hope that you'll be able to also cover antimicrobial resistance for the sake of the public. And of course, looking at the role of informing and entertaining, but for us in this particular instance, really to bring this information to the population in a way that will not scare the population, but actually just bring in a sense of responsibility and ownership in this problem that all of us have resulted in terms of, have contributed to in terms of the drivers that I already made reference to. And of course, just noting that as members of the fourth estate, you are both a window and a mirror. You reflect the views of the community, and you also reflect what is happening in society. So we are looking forward to working together with you to put this information in the right context to help us measure impact even in the society. And for this, we say that you're such an important partner in taking this information forward from science to the community and breaking it down so that the scientific messages are actually understood by different members of the community. Today, we are having this conversation because we want to be accurate on what we want to talk about. And there are so many reports that you can make reference to if you just went to the right and authoritative sources of information, so that you also reduce misrepresentation and distortion of messages. And one key myth that is out there is that we are the ones who develop resistance to the drugs, but it's the contrary. It's the microorganisms that are causing infections in us that actually develop the resistance and have said goes out and you're able to influence. You are such influencers in the society, with all of us having the goal of understanding what antimicrobial resistance is, to achieve understanding of our public responsibilities. For us who are in science, as a scientists, and for you who are in the fourth estate as people who are known for credibility in terms of sending out information, I think that is our goal at the end of the day. So as I conclude my session this afternoon, I just want to say that we are here to support you to produce factual, simple, hopefully, something that's intelligible and also timely information, knowing that you are trustworthy in health reporting. And I think when we do this, even our levels of awareness, because as you saw the report, very few countries have achieved countrywide coverage in terms of awareness. But you can imagine what one radio station does in terms of coverage. It can actually broadcast to the whole country, thereby just helping the countries achieve their goals within the National Action Plan. These are my takeaways today. Remember the reality that now AMR is a leading cause of death, higher than HIV or malaria. Number two, we are not doing enough. Much more needs to be done, and not just by the government, but every player in the society, the patients, the public, the healthcare worker, the politicians, the journalists, whoever it is that is using antibiotics needs to act. And the people who are providing the funding also need to continue to fund the interventions for sustainability. And of course, it's relevant for this moment. There's a loud warning signal. Already AMR is putting extra pressure on frontline health workers. It's becoming very hard for us to treat infections. That means it's going to be very hard for us to save lives in future. And what we also remember is that this is preventable. basic things can be done that can protect health systems and the population against AMR, like infection prevention and control. Basic hand washing can actually reduce the transmission of an infection by up to 80%. So you can see what simple interventions can do in a community. So I end with this. I want to urge all of us to just spread the word. I think that's your specialty. If you just take this and send it out to your populations or your communities, you would have had a ripple effect after this session. Support the prioritization in terms of advocating for antimicrobial resistance to be treated as a public health threat. So if you speak about it, people will listen more than just what the scientists talk about every day. And within your own countries, please continue to advocate for in-country mobilization of resources, not just the money, but the people as well, to be able to implement the actions within the National Action Plan. So I would stop at that point and just to appreciate all the partners that have supported a lot of the work in different countries to implement our national action plans. And I say thank you and hand over the session to the moderator. Thank you very much.
Thank you so much. Thank you very much, Dr. Evelyn, for this insightful and informative presentation. Yeah, before we go to the next presenter, I want to ask you a question. Please, others, you can keep sending your question in the chat box. Yeah, as we we have an increasing use of chemicals in different sectors, such as agriculture, livestock. So this is increasingly exposing the humanity in threat, into danger of AMR. So where you have in your presentation, you have highlighted some challenges, but I'm asking, where is the gap to address those challenges, and how best do you think the media should be engaged to address the challenges specifically? Thank you.
Maybe before Evelyn responds, Evelyn, I've looked at your last slide, and I think there's a logo that is missing there. I don't know whether you've realized.
Yes, again, I will add it.
Which one is it?
You know very well. I
will
put measure.
The measure logo is missing there conspicuously. But
Yes,
Evelyn,
yes.
Evelyn, I must commend you. I mean, when we started talking with you about 4 years ago, and the more we engage, the more I find that even the level of representation of facts and even the way you communicate the slides is just out of this world. Congratulations, and you are appealing more even to my heart, more than even to my writing, in terms of what you are, what you are talking about. And I think that one thing I also wanted you maybe to talk about. Please help me with those hooligans. Jacinta Mwangi. No, we just remove. Please remove Jacinta Mwangi. Riaga, remove her.
Yeah, please, you can, the host can unmute her.
No, just remove.
You can unmute, yes. Okay.
Okay. Yeah, so I was also just thinking that in terms of rallying the media towards, all these issues, I think you have a very important day at the end of the year. You can also just talk about that even as you respond to what my friend, the moderator, has spoken about. Because if we can have stories towards that week of AMR week and that kind of thing. And by the way, this conference was moved from its traditional November date to this date because of the AMR activities.
Okay, thank you, Dan, and thank you, Christophe. I think I'll speak to the gap, and the gap that can be filled by the media is what you call our objective 1. Increasing awareness and education and advocacy. There isn't any other sector that can do it the way you do it. You appeal to the masses, you have the convening platforms, you have the power, you have the capacity, you have the know-how, even in terms of just packaging information. So one of our biggest gaps has been getting support for awareness and education. And if the journalists can be able to just maybe step up and fill that gap, I think that's one of the areas where we can do a lot of work together, advocating and urging governments to invest more in AMR interventions. And of course, through your coverage and the different health slots, whether they're health or even primetime slots, talk about antimicrobial resistance as a silent pandemic. Just the way we have given coverage to pandemics like COVID-19, I think will go a long way. The other thing we can do as journalists is try to put a face to AMR. How can we personalize the problem? Because until it becomes personal, it's very hard for people to invest in something that they can't feel. And AMR cannot be seen or touched, you know, the way you would see many years ago an HIV patient, and you would be, you know, the picture would stick with you. It's not the same for AMR, unfortunately. The patient dies without anyone knowing that they actually had that infection. So that's a challenge. And now to the WOW, the World Antimicrobial Awareness Week, which happens every year from the 18th to the 24th of November. We want to invite Mesha to, and I know they've always been part of this, but now we want to step up our participation, either at country or regional level. Can we pull something together during the WOW week? I think that's possible if we can begin the planning early. And what we say, we can also drum up support for the WOW week ahead of time. We don't have to wait for the week of 18th to 24th. There's always a lot of competing activities. But what can Mesha do to be able to maybe ramp up support and advocacy ahead of the WOW week? So this is a global event. It's a WHO, OIE, FAO, and UNEP marked week to spread awareness and increase education on antimicrobial resistance globally. Thank you. Over to you.
Thank you. Thank you so much, Dr. Evelyn. In the interest of time, let's go to the next speaker. Kariuki Mugo is the Director of WASH Sector Support at Water and Sanitation for Urban Poor, a leading global organization that helps transform cities to benefit the millions who lack access to water, sanitation, and hygiene. He has over 20 years experience in managing poor urban and rural programs, and is an active influencer in the global WASH community of practice. His expertise is in building strategic partnership between public, private, and civil society sectors to strengthen enabling institutional and market capability required to increase access to sustainable WASH services for the raw income population. Over to you, Mugo. Thank you.
Thank you very much, Christophe. Good afternoon, good morning, all participants. It's my pleasure to be here, and I'll be making a presentation titled Hula Baloo about the loo and the new approaches for sanitation. In the interest of making this transmission flawless, I will go off video and I'll share my screen. Welcome to this session. Christophe, on behalf of everyone, can you see my screen?
Yeah, I can see it.
Okay, takes a little bit while to load. Okay, so as Christophe said, my work every day, I speak to governments, I speak to local, national, and regional institutions. I speak to international bodies, and my work is basically to make sure that this water sanitation and hygiene sector is progressing and moving in the right direction. My presentation basically will go through, typology, letting you know what sanitation is and why it is important. And because we are looking forward, we'll see the kind of knowledge that we have gathered as a sector in the recent years and what is new and what we need to teach each and every one of us. So without much ado, let me dig into that. So we know sanitation traditionally as, just fecal matter, what you take to the toilet and possibly after you're done with it, that is what we call sanitation. But sanitation is beyond the use of a containment facility, whether it's a toilet, flush, pit latrine, or whatever it is. So what we call sanitation is about an entire system of collecting, transporting, treating, disposing, even reuse of human excreta. We also talk of domestic wastewater, which is usually gray water, what we use for cleaning and washing, and also how we manage our solid waste from our kitchens and from whatever else. And sanitation, in modern definition, also covers hygiene and hand washing. So when you speak about sanitation, it's not just the toilet use, but we are talking about, in general, all these elements. In the course of defining sanitation, you'll hear many terms. You'll hear about safely managed sanitation. That is the highest level. We call it the aspirational level. Sanitation is about aspiration, is about dignity, and everybody wants to be dignified. So even the person who doesn't have a toilet, the person who practices open defecation on the right-hand side there, also aspires one day to have access to safely managed sanitation. So in this case, you'll see in the next slide that sanitation has different levels. We call them ladders. But for the sake of this presentation, we have safely managed sanitation. We have basic sanitation, which is where you have a toilet and is not shared with other people. When a toilet is shared with other people, we call it limited sanitation. The reason being is that we recognize it as improved sanitation, but as a matter of fact, it is very hard to enforce certain standards of hygiene. So it's not a very recommended level of service. It's something that is very transitionary and is used by people because they're in movement, or maybe they're not in a position to afford a private sanitation, and that is what everyone aspires. Then you also have an improved sanitation, the traditional pit latrines. Usually it's a simple pit with logs or sticks on top or something like that. That is what we call an improved sanitation, and we have open defecation. So that is usually represented in a ladder with open defecation on the left-hand side at the bottom. It's what every community evolved from. In the West, you have the highest level, which is the safely managed sanitation for almost everyone. In developing countries, we struggle between an improved and shared. That is where most of our populations are. And of course, as you see in the next slide, we have quite a huge population in developing nations practicing open defecation, and that's a very serious public health risk. Now, from this diagram, you can see there's some text there. So there are different things you need to do to move a population from one level to the other. For example, if you want to move a society from open defecation to an improved sanitation, you need to do a lot of behavior change communication. You need to teach people about the options, and you need to coordinate, various elements of people being able to access basic materials for latrine construction. And then when you want to move people from an improved level of service to basic level, you do different things. You work on supply chains, and we'll talk about that later. You look at technologies, you see how they can access finance. You become more considerate of different stakeholder groups and the vulnerable, and you also think about gender. So you have different things that you do at various stages to be able to enable people shift from one level to the next one. But in the end, everybody wants to be at a safely managed sanitation level. And that is what we should work towards and enable each and every person in our countries to attain. Let's now talk about why sanitation is important. In terms of the numbers, the most recent numbers is that we have 3.6 people who lack safely managed sanitation. So most of them are doing open defecation, and they're using unimproved toilets, or they're on shared level. So out of that 3.6 billion, 673 million people globally practice open defecation. Now, we all know that these numbers are from developing economies, and most of those countries are in Sub-Saharan Africa. So this is our problem mainly. You'd be surprised that a huge percentage of these figures are from our continent and even from our own countries, and whatever we are in this conference. The other numbers that are quite alarming is that 1.7 billion children mainly contract diarrhea, and close to 500,000 of them die annually. We have 3 people contracting cholera across these regions, and almost 100,000 of them dying. And we have 11 million people contracting typhoid, and over 100,000 of them dying. Now, these numbers look small, but if you compound them, and even looking at the previous presentation by Evelyn, 100,000 doesn't look like a big number, but if you compound all these public health risks, you end up with hundreds of millions of people, and we need to pay attention to that. Now, there are a number of initiatives trying to move the world towards 100% access to safely managed sanitation, but it's not easy. And 2 of the critical things that stand in the way, number 1 is lack of organization by our governments and to put other stakeholders around the table. And the next one is financing. For example, in Kenya, 64% of the country's investment in sanitation is from donors. So basically grant financing, meaning you can hardly track the level of public finance or budgetary support that goes into sanitation, and especially non-sewer sanitation. If there's allocations going to sanitation, they mainly go into sewer sanitation. And what does that mean? It goes to the higher social classes, and because sewerage is very expensive, it's normally highly subsidized. So the rich gets a subsidy, the poor are left out because they have no way to access sewerage, and they can't afford, even when there is sewerage, there are no connections. If you look at Africa, most of the sewerage investment across the cities, we are paying loans for that in one way or another, but yet it traverses through low-income areas, and poor people don't actually have access to it. So in terms of what Kenya has been investing, it will take about 200 years for people to achieve universal access to sanitation, and that is impossible. So something needs to be done, and we will see what needs to be done. So the sector has come a long way, and from a distance, we've always, like I said, we've always thought of sanitation as just latrines or just a way to dispose waste, and that has been a big problem because we, unlike for example what Evelyn was presenting, the health sector started to think about systems, health management systems many decades ago. This is a time the water sector, water sanitation hygiene sector is waking up to the fact that sanitation is a system issue. So one of the things that we have learned is that there's a value chain for sanitation, and that begins with containment. That begins with containment, and containment is the facility where the user first interacts with a sanitation chain. So it could be a pit latrine, it could be a flush toilet, it could be a pour flush toilet, it could be a public toilet, it could be whatever it is. That is what we call containment. And then the next one is called emptying. I know also people connect more with rural sanitation, where emptying is not a common thing. You know, you dig one pit, it gets full, you move on and dig another one. So it's never a big issue. But in urban areas, that is very critical. You have no space to keep on shifting latrines, you know. So emptying is an important element of the value chain. Then you have to transport that to a treatment facility, and then where it's treated for reuse or for disposal. So this is one of the critical learnings, that sanitation has a value chain. And if you're planning for a toilet, you must think about how all these other pieces will fit to the end. Now, the second critical learning is that sanitation value chain comprises of private goods and public goods. Let me explain this. Private goods are what can be in the private sector domain or are within the control of a household. So when you talk about a water closet, you know, the flush toilet or something like that, or a septic tank or a latrine, it's a household that pays for that. And usually a household can pay for that if the right options, affordability options are provided. Things like pit emptying were required, the household can pay for that. You know, so what you see here is light blue is what we call the private goods, and the household can be able to pay for that. But when it comes to offtake, you know, the sewer network, the sewer treatment plant, reuse and disposal facilities, the household can be able to meet the cost of operating that. So the public subsidy has to come in. The government has to come in, build all those facilities to enable the sanitation value chain become functional. So understanding this is important because we are able to see where the private sector can play a part, and it can play a part, a good role in the public goods and services domain. But it can be able to play part in in private goods, can play part in private goods, and it can play part in public goods and services because the household can be able to pay for it, and it interferes with business viability. So separating these two and having different conversations with private sector on one hand and public sector on the other hand, and trying to connect the two is really critical in moving this sector forward. The third thing that we have learned, which is important, is something called the sanitation economy. That there is big business in sanitation. And the sanitation economy is divided into three elements, which is a toilet economy. So how do you construct toilets? How do you empty them? How do you, what I've talked there before, how do you treat the waste and that kind of a thing. But then you also have the circular sanitation economy, that you can be able to, instead of just treating waste and disposing it, you can actually reuse some of the products. You can recover value from fecal waste or even solid waste, and generate value out of that. And I'm sure most of you have seen a number of initiatives, whether it's composting, producing manure, others are producing fertilizers, others are producing animal feeds, others are doing fuel briquettes and logs. So that is what part of the sanitation circular economy. Others are recycle water and use it for irrigation for loans and that kind of thing, and golf courses. So that is also important. And the other one is the smart sanitation economy, which is how the sanitation system interacts with technology to make it more progressive and more efficient. So if you look at, for example, I've given an example of Kenya, is a 3.2 billion market, and it's projected that by year 2030, the sanitation economy in Kenya will be worth 6.2 billion shillings. So looking at all these elements and seeing where the value is and enticing different players to come into the market and cash in on the market is really critical in moving it forward. So let's see what's the new things and how we are trying to do things differently from the past. The past would be, you have a public health laws and people need to dig toilets or connect septic tanks, and then you come and enforce and arrest them and prosecute them and then tell them, all manner of things. But of course, we all know that the government can't prosecute everyone. So those are old ways of doing things. So there are a number of elements that need to be brought together. And today, in the sanitation community of practice, there are a number of things we are looking at. And first of all is enabling environment. Does the government have the right policy? Do we have institutions that have designed, structured, staffed, resourced to be able to deliver sanitation? And in most cases, I'm talking about non-sewer sanitation, because our institutions are there that provide sewerage and that kind of a thing, but we have moved from that mindset that sewer sanitation is going to be a solution, is not going to be our solution. So do we have institutions with skills, expertise, resources, plans, financing and all that to be able to deliver that? And do we have regulation to be able to manage that market and interaction of customers, of service providers and policymakers? So these are governance issues. And if you look at Africa, we have African Minister Council on Water and Sanitation, AMCOW. It's an AU institution based in Abuja. One of the things that AMCOW has been doing is something called ASPG, Africa Sanitation Policy Guidelines. And they've been driving that process and trying to make each and every government have a progressive sanitation policy, because that is a starting point. And of course, that will be followed by institutions, systems, and regulations. And that will see different kind of momentum being built in increasing access to all African people. The second thing that is happening, and we are talking a lot about it, is how do we improve collaboration and coordination? Number one, coordination within the sector. So how does the government bring in a private sector? How does it bring in academia? How does it bring in the fourth estate? How do we sit around the table and have conversations and communicate and create understanding and rally for support from each and every stakeholder? And the other one is collaboration. How do we design programs, that all end up contributing to the same objective, So how do we do that? And also, how do we collaborate outside the sector? The water sector has been a very marginalized sector. It is actually, the water sector has been seen to be very, very unimportant in terms of economic development. And particularly sanitation has been, even within WASH, sanitation is the most neglected. So how do we build in greater collaboration with our sectors, like housing, like health, like public service? How do we do that so that when people are planning for roads, they're planning for drainage, they're planning for solid waste management, when they're planning for housing, they're including sanitation and planning for progressive wastewater treatment facilities, those kind of things. So seeing how that ecosystem of collaborators and stakeholders come together. So users, again, within the sector, the users, the entrepreneurs, utilities, and authorities. How do we see them coming together? And that is supported again by the enabling environment. There's the issue of behavior change communication, and this is very key because most of you come from the communication background. And we saw that to move people from open defecation to the other levels, you need to change their behavior. So trying to build in behavior change as a critical element of driving sanitation and changing sanitation and hygiene behavior is key in increasing access to basic sanitation. So this has become a critical element in the sector. And of course, anyone trying to do something without building in behavior change communication will be frowned at and is likely to resort to failure. So this is critical, and I think some of you must be very much well involved. And I think as time go by, and even the call we're going to make to you is that keep on communicating these issues, making them public, because you have a great stake in influencing how people behave and how people perceive development issues. The next thing that we are keen on is sanitation marketing, knowing that sanitation, within the sanitation economy, there's a huge market, and that market needs to be structured. So like we saw earlier on, to move people from basic sanitation to improve sanitation, you need now to catalyze the market, okay? You need to have products, you need to have, to drive those products to the market, you need to have maintenance and distribution channels, you need to have emptying services, you need to have treatment facilities. Putting together the different elements of the market is what we call sanitation marketing. Such that if you want to build a toilet, you can go somewhere and buy a wash basin or a sand plant, very simple plastic slab, if that is what you can afford. You can get somebody to empty your pit manually, or somebody to bring in a vacuum tank to empty, depending on how you can afford, and all sort of things. So putting together the different elements of sanitation marketing is really, really critical. The other issue that we are looking at, and I'll mention this as a final one, is financing. And looking at what can bridge the gap between what the government can afford, what the household can pay for, and the in-between. That has been a big, big problem, because without that in-between, then you can't have the private sector coming in to connect the private good and the public good, the private service and the public service. So we have to look for different ways of financing sanitation. We must talk to banks. We must look at what grant schemes exist. We must look at loans and where they are being channeled to, not just trunk sewers, but government loans from development banks going into building toilets, or they're continuing to deepen marginalization. The issues of climate change, which are key in the wash sector, are we tapping into the green bonds and green financing, all sort of things? Are we looking at microfinancing schemes, the taxes, issues of local taxes, and how you can use levies and surcharges locally to generate resources to reduce marginalization is becoming critical. And one of the things that we are struggling with, how do we enter equity and bonds markets, and how can we leverage on pensions and the like to be able to finance that missing gap? So we have seen, just a sec. We have seen the new things that are happening. We have seen the new things that are happening, financing, think about value chains, communication, connecting private and public goods, and understanding sanitation economy. And all that is basically meant to help build stronger stakeholder relationships, is meant to create understanding of how markets are structured and how they relate with each other, whether it's a health market or sanitation market or the water market. How do they come together and how can they be connected better? We're talking about building multidisciplinary skill sets. Our sector has been very exclusive, mainly for engineers. And now we are seeing, and of course, at some point, public health experts, but now we have all sorts of skill sets, whether it's business from the business side of things, whether it's sociologists, whether it's media and communication. We are embracing different skill sets. And this is actually making this sector start to transform. We're eliminating barriers and bias, seeing what some people deserve and others don't deserve. So we are trying to deal with that. We are developing value for everybody, and you're trying to manage, risks, and innovate to manage risks, improve access, and build credibility even for financing. So my call to all of you is that being in the media fraternity, please create awareness on the socio-economic and environmental value of sanitation, because sanitation stands in the way of economic development. Countries lose billions of dollars every year because of sicknesses, because of inability of people to go and work, and all sort of things. So we have huge socioeconomic and even environmental value, which is self-explanatory. Please help us highlight sanitation as a critical marginalization and public health risk issue. Like I said, the poor deserve, the rich deserve, the poor don't deserve. And again, if you look at issues of gender, you have girls in schools not being able to attend school when they're menstruating because they can't access toilets or they don't have a proper menstrual hygiene management, basics. So it's a critical marginalization issue. The rural poor versus the urban rich are completely different. So it's quite sensitive. And of course, the public health issue. We've seen how cholera spreads and typhoid and how they affect the population. And that is also, again, people at the bottom of the pyramid. It is important for the media to track how the country is shifting from traditional to progressive approaches. I've talked about the new movement for policies. Does your country have a new policy that is supporting a progression of sanitation? Are we seeing institutions coming up? Are we seeing new technologies and private sector being encouraged to provide access to the people? And I think finally also, and that is up to attaining the MDGs by 2030. But besides that, we need to hold policymakers to become responsible for providing basic human and constitutional rights. We have seen a movement in Africa where a number of countries are starting to include sanitation and water access as basic human rights, and we need to start pushing the button for people to take responsibility, allocate resources, and help our people. Thank you very much.
Yeah, thank you very much, Mugo, for this insightful presentation of initiative that is doing that much in fighting against AMR, preventing against AMR. So before we go to the next subject, I want you to ask you something. Dr. Evelyn has mentioned policies and policy implementations, and is one of the challenges. As you, who is in civil society, who is implementing such initiatives, how do you think civil society, as well as, of course, the media is in civil society, can help in overcoming that challenge of policy on national level? How the challenge of the absence of policies, strong policies, and the implementation of the available policies are affecting the initiatives such as that one, and how civil society do you think can help in establishing stronger policies and making sure that they are being implemented?
Okay, a very broad question. Let me try to attempt it in bits and pieces. And first say that policy is what gives a government's commitment towards achieving or solving a certain problem that affects its people. So if a government doesn't have a policy, it has not made any commitment to resolve that issue. So if there's no policy, then there's no commitment. So nothing is going to happen. Now, when you don't have a policy, you won't have laws, what you call acts of parliament or acts of, municipality or whatever it is. So you have no laws that govern how things should be done. And without laws, you can't have regulations. So you can't say, don't dump here, don't do that, don't undercut this, don't overprice, this service, that kind of a thing. So it becomes very, very difficult. But the biggest effect of not having a policy, apart from lack of that commitment to the public, is you can't have an institutional, a sound institutional arrangement. Meaning that if you look at sanitation, in a country where there is no policy, and actually is almost everywhere in this continent, you have like 10 or 20 ministries, departments, parastatals claiming to have responsibility for sanitation. And what they do, instead of providing a service, they compete for resources. So, their competitors, they don't collaborate, they undercut each other, they take budgets that they can't utilize. And what happens is you lack accountability. So even what is allocated, you can't trace where it has gone because no one has responsibility and nobody can be able to follow up where it is. So lack of a policy means you're not going to have a service. And that institutional mishmash leads to other problems. When you have civil society that comes in to plug in the gap, what the civil society, and maybe that is where the civil society can help. The civil society over the years has tried to provide services on behalf of the government. So the government is not providing services. So civil society comes in to try and build toilets and do that and all sort of things. But the responsibility of providing services to the people lies with the government, not with anybody else. So it's a high time the civil society came to realize its role is not to usurp or to replace government. It's actually to help governments overcome the challenges, because there are a lot of challenges. Even we can't entirely blame the government. We need to contribute, give ideas, give support, help in reforms, do some advocacy here and there. So civil society needs to focus on making the system work. We say people don't have the system, the sanitation, because there is lack of technology or there isn't enough money, is because the system is broken. So let's fix the system. And that system is governance. So we all contribute to governance. And then out of that, we're going to see a big change.
Thank you. Thank you so much. In the interest of time, we have to move to the next speaker. Please keep your contribution and questions flowing in the chat. Let's now tackle the issue of reproductive health, the subject of reproductive health in Africa.
Yes, Chris, there's a big one here. Agatha is asking Mugo to say again that, did you say that it will take 200 years for the world to achieve universal sanitation? Mr. Mugo, can you say that again?
Just in a minute, just in a minute, to make sure that we are using our time efficiently.
Yes, I just said, I gave the example of Kenya. And then I think Kenya is one of the countries that's quite progressive in providing sanitation. So if at the current level of investment in improving sanitation in Kenya, it will take 200 years. You can be sure most of the Sub-Saharan Africa countries will do double that. So it's even worse in other markets. Thank you.
Oh, great. Thank you. Let's move to the conversations that matter about productive health in Africa. We have the next speaker on this is Nduta Wawelu. Is the national team coordinator communications at DSW Kenya. She has over 12 years experience as a journalist and communication specialist. Passionate about sexual and reproductive health and the rights, Nduta's work has been featured in various publications highlighting the issues and solutions to existing challenges. Wawelu, you welcome to this panel. You have 30 minutes to break this down. The mic is yours. Thank you.
Thank you very much. I hope everyone can hear me. I will share my screen and get right to it. One second. As you've all heard, my name is Nduta Waweru. I am the National Team Coordinator for Communications at DSW Kenya. And DSW is global development, is a global development organization founded and headquartered in Germany. But we also have DSW Kenya, which is an non-governmental organization that is registered in the country, and it's one of the East African country offices of the DSW headquartered in Germany. So we do work in Kenya, Uganda, Tanzania. We also have Ethiopia as well. And one of the key things we do as DSW is we are committed to creating demand for and access to information, services, and supplies for the youth. And for us, the youth, we use the WHO definition of the youth, which is 15 to 24 years old. And this is a very special target to us because in the country and on the continent, we have a very young population. And we want to get to talk to them and let them know about reproductive health as young as we can and as young as we are permitted to, so that by the time they get into their reproductive age, they are able to make decisions, they're able to find information, they're able to find services and so on, so that they can secure their bright future. So we do this in different ways. One of them is advocacy. Advocacy definitely, we advocate for all the things I've mentioned, that is access to reproductive health information, to reproductive health services, and reproductive health supplies. We also do capacity development. We work with youth groups in different regions, in the country and out of the country, where we enable them to work with themselves. They are able to figure out things to do with group work, working in a youth group setting. We talk about how they can manage their finances as a group, the kind of economic activities they can do, how they are able also to talk about reproductive health as well. We also have family planning initiatives. So we are able to do this by the advocacy, and the capacity development also contributes to the family planning initiatives. And we are also working with different organizations and different county and national government to ensure that we do have family planning products, family planning services for everyone, and especially the youth. So basically, as I said, our main aim is to make sure that the youth of today are able to lead healthy and self-determined lives. And we have a number of programs in different counties, and you can see them there. This is the Kenyan office we are talking about. So we have Bungoma, Kisumu, Kilifi, Kwale, Laikipia, Meru, Mombasa, Nairobi, Nakuru, Nandi, Nyandarua, Trans Nzoia, Uasin Gishu, and West Pokot. So let's get into it. Why must we talk about reproductive health? Reproductive health is one of the biggest components of general health. Some of the biggest issues people face in terms of general health actually come from reproductive health. And it is one of the rights. For Kenyans, we know the Constitution says that we must have optimum health, and we can't have optimum health without reproductive health. So basically, we need to make people understand that they have exercise of control over their own sexual and reproductive health, because this also is linked to human rights, and it includes a number of components, one of which it is, as I said, a component of overall health throughout their life cycle for both men and women. Reproductive health covers a number of things, and one of them is also menstruation. And we know in our African culture, we like to say, now you've become a woman because you've had your period. But that is a huge component, because the period also it can affect the kind of reproductive health that you have. What are the issues you're facing? And also, in a sense, it can affect your overall health. Issues to do with STIs, HIV also is a component of reproductive health. So without having the concentration of reproductive health, you're ignoring a very major component of your own general health. The second thing, we have reproductive decision making. This is very important because it gives an individual a choice whether you want to get married, whether you want to have a family, if you want to have children, what is the timing and spacing of your children. And then it also includes the right to have access to the information so that you can make the decision about your reproductive health and about your voluntary choices in terms of family. So without that right, without having to access that information, without having to access the services that you need, chances are that your voluntary choice in your marriage and your family may not necessarily work out as you want to. We also, reproductive health also is connected to equality and equity for men and women. So definitely, there are quite a number of cultural issues that we talk about across the continent that may affect the equality and equity between men and women. Child marriages is one of them. There is FGM, we can talk about that. So those are the things that will impact the kind of agency for an individual to make a decision. If you're married too young, especially in cases where you're married to an older person, chances are that your ability to make your own decisions about your own body, about your own choices, reduce tremendously. So those are the things that we need to get rid of so that equality and equity can come through and people are able to access reproductive health. And finally, sexual and reproductive security. This is very important because it includes the freedom from sexual violence, it includes freedom from coercion, and it gives people the right to privacy. However, young people are struggling with SRHR. And according to statistics, there are quite a number of issues that that indicate that many young people are struggling with SRHR. One of them is that we have one of the highest maternal mortality as a continent. So according to statistics from 2019, it indicates that about 546 women out of 100,000 face maternal mortality. They die annually because of maternal issues and maternal health problems. In terms of teenage pregnancy or adolescent pregnancy, across the continent, 4 in 10 girls are pregnant. In terms of access to modern contraception, over 214 million women across the continent want to access contraceptives, but they cannot. So As a continent, only 28%, as at 2019, 20% of women reported that they were using contraceptive as a continent. In terms of HIV and AIDS, statistics from UNAIDS indicate that 25.6 million people on the continent live with HIV. And what's sad is that women and girls represent the majority, and usually the age group between 15 to 24 years are 2.5 times more likely to be infected compared to men. So definitely we have seen there is an issue there. When we come to Kenya, according to the National AIDS Council World AIDS Day Progress Report 2013 to 2021, we can see that 1.5 million people, women were the new ANC clients. About 38,000 deliveries were from HIV positive women. 16.9 or 17,000 is the number of adolescents aged between 10 to 14 who presented with pregnancy at their first ANC visit. 31,400, around 31,462 is the number of adolescents aged between 15 to 19 who presented with pregnancy at their first ANC visit. About 331,000 is the total adolescent pregnancy, and 22.6% is the proportion of adolescents attending their first ANC. In the second diagram, it indicates the HIV infection. So, and you can see here, particularly in Kenya, 61% of all adult new HIV infection came from the age group of 15 to 29. So definitely there is an issue there, and we must be able to address that to make sure that we address the reproductive health challenges that we face. So when we talk to the young people that we work with, they come out and tell us some of the things they face as a group. One of them is that there is issues with awareness. A number of them are not aware about some of the sexual reproductive health issues, including menstruation, including contraception, including sexual gender-based violence. And because of this, they are not able to actually go out and demand for their services or demand for information. Usually, most young people talk to themselves. They don't have that agency, because also there is quite a number of things that prevent them from accessing services or demanding for that particular services. So the consequence of this include low uptake of contraceptives. If I do not know the kind of contraceptive that is available and is suitable to me, chances are that I wouldn't use any. Unintended pregnancies, because you are not able to access contraceptives, or you're not able to access sexual and reproductive health information on how to prevent pregnancies, including abstaining, your chances of getting unintended pregnancy is high. And safe abortions is also another consequence, HIV and STI infections, as well as SGBV, sexual gender-based violence. Myths and misconceptions also drive poor demand for the services. Quite a number of things came up when we were discussing a few things with the young people. Some of them believe that contraception can make them infertile. So if I'm a young person aged 19 and I'm planning to have babies when I'm 25, I can't get on contraception because I'm afraid that I will become infertile and I won't be able to get the children I want when I turn 25. Yeah. Others believe that you cannot get on contraception or family planning if you've never had a child. So most of them wait out until they have a child before they get on contraceptives. Others include that they're afraid. Others are afraid.
If your dad's sick. Yeah, it's on that section of your cupboard where you.
Excuse me.
Yeah. Kindly mute Ida.
Okay. All right. I was saying others believe that you're promiscuous if you are on contraception, and some people want to be seen as not promiscuous.
Unasikiza very keenly.
So
Doreen, kindly mute. Thank you.
Some of them feel that they'll be judged, that they're promiscuous. Others think that their libido is it will be interfered with, so they wouldn't want to have to get on family planning. Other issues that come up include that you might lose weight, you might lose your hair, you might gain weight and all those. So those are some of the misconceptions that we have come across. But also, besides the awareness factors, there are some of the things that relate to service provision. For example, somebody is aware that the kind of contraception that suits them, they're aware of what it is, and then they go to a health facility. But when they get there, they do not get that particular kind of product. So in the end, they can't. Some of them feel it's difficult to switch from one commodity to another. Others, the commodities available do not suit them. So in the end, they don't use the particular contraceptive they need. The youth also complained about a number of things in terms of service provision. They say that there are quite a number, there's a lack of trained personnel on SRHR service provision. And usually in terms of trained personnel is how to engage with young people. Some of them have that skill to provide the services, but they cannot relate with young people. This could be because of a number of reasons, cultural, infrastructural, and all that. But that lack of trained personnel contributes to many young people being shy. They don't want to go to the services, to the facilities to access that service. And also there is the lack of youth-friendly facilities. So youth-friendly facilities in DSW definition is a facility that has combined services in terms of health provision, in terms of service provision, and in terms of approach of the personnel. It should be attractive to young people. It should meet the needs of young people comfortably and responsively, and it should also be able to retain the young people. So those are the kinds, that is basically some of the parameters that fits into a youth-friendly service. But as I had mentioned, there are some facilities that do not have, there are some counties that do not have, and some counties that do have, they also face all these a number of these limitations. So I'll now switch to what DSW is doing to change this, and I will play a video. I hope you will be able to hear it. Please let me know that you do.
Yeah, we cannot hear it, Nduta.
You cannot hear it?
Yeah, but I would like always to even to remind you that you have more 9 minutes.
I have 9 minutes. Okay, then.
Yes.
So let me just go right to it. One of the things we're doing as DSW, we call it social accountability. And social accountability is a citizen-led action to hold public officials and service providers in the use of public resources and delivery of services. So basically, it's just bringing the citizens to make them aware of what the public officials' responsibilities are and the service providers' responsibilities are, and that they should be able to bring that out. So the mechanisms that we use for this include a community scorecard. A community scorecard is where we bring together the service providers, the users of the facilities, so that they can come and tell us what exactly is going on. Are family planning products available in the counties? Are youth-friendly services available in the counties? And things like that. Budget analysis will break down the budget allocated for different counties to facilitate family planning, dissemination and availability. And then because of the budget analysis, we also have the public expenditure tracking. The public expenditure tracking now checks out if the budget that was allocated for family planning has been used for family planning. and how much, what is the discrepancies and things like that. We also have public hearings. This is basically public participation. And here we also enable the young people to come and present their issues in front of all the stakeholders. Could be county, could be regional, could be national, could be even international, where they talk about what they face as young people when they're trying to access SRHR. So basically the objectives of this is to access community satisfaction with the services, to support the community to identify gaps in service provision and budget allocation, and also to increase demand for SRHR budget expenditure and quality of services in different counties. The other thing we do is a new platform. It's called Life Yangu. Life Yangu is, we launched it last month, the 28th of April. It is a platform where young people access age-appropriate and relevant information on reproductive health. So basically, we provide them with all the information. We also link them to facilities that offer reproductive health services. So basically, if you're in, we currently have 2 counties, that is Mombasa and Kisumu. So if you are somebody in Mombasa County and you access Life Yangu, it can tell you where to go to get this particular service. So the age group target for this particular products is 18 to 24, and we want to make them aware about reproductive health and contraceptive services. We also want them to be able to make their own decision or take the initiative to seek health services in terms of reproductive health. And then this is another video. Since it can't play and we don't have time, we'll continue. So basically,
but you can still share the link into the chat, yes, so that we can watch the video.
I will do so. I will do so. So Life Yangu is, it took a number of planning. We were able to interact with the county government of Kisumu and Mombasa, and they provided us with the facilities. And keep in mind, these are public facilities, not private ones. So the young people are able to go out there and access these services as they need to. And also the platform provides information about all the myths and misconceptions. They answer those questions. They provide all the number of contraceptive products that are available, the advantages and disadvantages, so that the youth is aware of what they are looking out for. And the reason we linked the information to the facilities is because we want to encourage young people to go to the facilities, and we also want to encourage them. Like, there is no one without the other. It's a circle that we're trying to make sure continues all through. That is my presentation. I welcome any questions, any clarifications. Thank you.
Thank you so much. This is very, very educative. Yeah, I have seen in the chat that in some parts of the country, there are already facilities, but people are not going for the service. To address this challenge, what would be the contribution of journalists, of the media?
Thank you for that question. One of the most important things the media can do to help is to create awareness about the importance of youth-friendly services. Because one of the biggest reasons, as I'd mentioned before, is that some young people do not feel confident enough to go to a facility, because usually where the reproductive health services is provided is in an open space, or is just somewhere where they can see their mothers, they can see their aunties, and so on. So they're a little bit afraid in terms of that because of the stigma that surrounds reproductive health. Other things, especially in a community where young people are considered should not have sex, are considered that they shouldn't have sex, and they shouldn't access these products, it's very difficult for young people to actually have that agency and have that courage to go out. So it would be very important for the press, the media, to come out and, one, highlight those challenges that the young people face, the shyness, the lack of privacy, the lack of confidentiality, the issues to do with stockouts. All those things should be highlighted so that the account holders, the stakeholders can come out and fill in that gap. Secondly, all conversations should be very non-judgmental, because even with press, sometimes there are some information we provide in a biased kind of way, and that also marginalizes the youth from accessing reproductive health services and information. So providing an unbiased report, an unbiased analysis of the situation would go a long way to encourage young people to look for these services.
Thank you so much for that presentation and the information within it. So I think whatever we do could not be achieved without real data to inform, or real findings to inform our decision. That's of course a fact. Yeah, let's see with the next presenter on. Let's see how we can turn research results into action. We are going to see the case of Leishmaniasis East African platform. Is going to be presented by Simon, for Simon Bolo, in charge of Leishmaniasis access reader at DNDI. Bolo, I think you can hear me clearly. Yes?
Yes, right? I can hear you. Can you see my screen?
Yes, I have it. But before you go, let's tell the audience a little bit about you. Simon is currently the head of Leishmaniasis Access for Drug for Neglected Disease Initiative, DNDI, in Eastern Africa at the African Regional Office in Nairobi. Prior to this, he headed the operations portfolio at the DNDI Africa Regional Office. He has over 20 years experience in financial administration and operational management, progressively gained in the private and non-profit sector. Bolo, yes, we can hear, we can see your screen and we can hear you very clearly. Yeah, the floor is yours to break that down. Thank you very much.
Thank you very much, Christoph. Good afternoon, everybody. Yes, today I'm here to present to you our work where how we turn research into results, or rather research results into access. So I will briefly talk about who we are as DNDI. So DNDI stands for Drugs for Neglected Diseases Initiative. It's a nonprofit organization which was created in response to the frustrations of clinicians and the desperation of patients who were faced with medicines that were either ineffective, were unsafe, unavailable, sometimes unaffordable, and even were never developed. So this problem was because the then and current profit-oriented model for medical research and development does not provide enough incentive to develop drugs for the poorest and the most vulnerable members of the communities. So in 1999, the famous MSF, Médecins Sans Frontières, dedicated a portion of its Nobel Peace Prize to develop this organization in collaboration with 6 other partners, one of which is our premier research institute known as KEMRI. So our mission is to improve the quality of life of people affected by, or rather of neglected patients. And we do this by conducting clinical research and coming up with new treatments. WHO lists about 20 neglected tropical diseases, and we work in about at least 6 of those diseases. And in addition to that, we are also working in other diseases that present neglect to the patients that we work with. In the 20 or so years that we've been in existence, we've been able to successfully come up with 9 treatments, which is no mean feat. Usually in this industry, it takes quite a lot of time, sometimes up to 15 years to just come up with a new treatment. So we can pretty say that we've been very successful as an organization who are depending mainly on donor funding to develop new treatments. And what is very clear here is, and what I'll be speaking on most is the treatment that we brought in 2020 on SSG and PM for a disease that we call visceral leishmaniasis. So my presentation focuses on leishmaniasis, which is a disease that affects quite a number of people worldwide, and the East African region that consists of Kenya, Ethiopia, South Sudan, Eritrea, and Somali have a global burden of about 57%. Over 14,000 deaths have been associated with leishmaniasis every year, and up to 70% of VL patients, that is visceral leishmaniasis, are children. So what are the various forms of leishmaniasis? It presents itself in different forms. So 3 major forms. So one is cutaneous leishmaniasis, which causes skin lesions, mainly ulcers on the exposed parts of the body. And then we have mucocutaneous leishmaniasis that leads to partial or total destruction of mucous membranes of the nose and the mouth and throat. Then there's a visceral leishmaniasis, which is fatal if not treated. It has its own various forms. There's a primary VL, but then there's what we call post-calazar dermal leishmaniasis, otherwise known as PKDL, which is a complication of the VL and is characterized by a rash in the patient who has recovered from the treatment of VL, but is otherwise well. And then there's the HIV VL co-infected patients whom we see mainly in the northern part of Ethiopia. So to dive deeper into visceral leishmaniasis, it is one of the deadliest parasitic diseases after malaria. It is caused by an infection with Leishmania parasite, which is spread through the bite of a female sandfly. The affected regions are usually remote, unstable, with very limited resources for treating the disease. It affects really the poorest people in the community, and is characterized by prolonged fever, enlarged spleen and liver, substantial weight loss, progressive anemia, and is, as I mentioned before, is fatal if left untreated. Its distribution within the Eastern African region that I talked about, as you can see, clearly very present in Kenya, Ethiopia, Sudan, and South Sudan, Uganda as well as Somalia and Eritrea. And like I'd mentioned, it harbors, Eastern Africa harbors the highest burden of VL worldwide, with 30 to 40,000 new cases seen every year. VL affects really mainly the poor communities in remote rural areas. And as I mentioned, majority of the patients are children. In Ethiopia, that's where we have the highest burden of HIV VL co-infection. And while in Sudan and South Sudan, we have the PKDL, and then up to 60% of VL cases develop PKDL within the 0 to 6 months after treatment. It is, however, less common in Kenya, Uganda, and Ethiopia. So what is our strategy as BNDI insofar as visceral leishmaniasis is concerned? So we have a long-term strategy and a short-term strategy. In our long-term strategy, if you can see the figure on your screen, presents our R&D portfolio, where we have on the left side what we call new chemical entities that we are developing from scratch. But then more to the right side, we have a mix of what we call treatments that have been in existence and that we've repurposed for use for visceral leishmaniasis. So our objective for the VL program is to deliver a safe, effective, and short-course oral treatment for visceral leishmaniasis, a new treatment for post-Kalaza dermal leishmaniasis, and PKDL is been known to be a reservoir for the spread of, or rather for Leishmania parasites, and as a result is known to cause the spread of Leishmaniasis in the region. And then our third strategy or objective is to deliver treatment options for HIV-VL co-infected patients. And we do this while responding to the WHO NTD roadmap, which is to develop user-friendly treatments, specifically oral treatments that we can move with towards the elimination of the disease. And as we do this, we are contributing to the sustainable elimination of VL in Asia, and of course, disease control in Africa and Latin America. So up until last year, our short-term strategy has come up with, developed different treatment options. So the current first-line treatment for visceral leishmaniasis is called sodium stibogluconate and paramomycin. It's a combination of two different drugs. But up to last year, we conducted a phase 3 study, which is recommending a new treatment option for visceral leishmaniasis. So that would be paramomycin and miltefosine. Miltefosine is the first oral drug to be ever used for the treatment of leishmaniasis. And what this combination brings in is on one side removes the related toxicity associated with the SSG, and treatment is also expected to be simplified because of ease of administration due to the oral drug, and the hospital stay is going to be reduced by 18%. On the HIV-VL, we've been able to recommend a treatment combination of liposomal amphotericin B together with miltefosine, and currently we are waiting for WHO to recommend this for use in Ethiopia, so that we can be able to change the guidelines. And finally, we also recommending new treatments for PKDL, that is a combination of paramomycin and miltefosine, or ambisome and miltefosine. The results of the study are very promising, and we are going to propose that or recommend that for use in the East African region. Now, over the years, the clinical research activities have been conducted in the East African region through a platform called the Leishmaniasis East African Platform, otherwise known as LEAP. DNDI's modus operandi is to work through partnership and develop disease-specific platforms for ease of solving the problems related to a specific disease. So LEAP is one such platform. We have two other platforms, one in Latin America, specifically for a disease called Chagas, and the other one in DRC that deals with human African trypanosomiasis, which is endemic in the Central African region. So LEAP is a clinical research network that brings together experts from leishmaniasis endemic East African countries to facilitate clinical testing and improved access to better treatments for leishmaniasis in Africa. Since inception, we've been able to conduct more than 10 clinical trials, And the current first-line treatment for visceral leishmaniasis was out of a clinical research that was conducted by LEAP. It was founded in 2003 in Khartoum and has a membership of 60 from 20 different institutions. And as I've said, its main mandate is to facilitate clinical testing, build capacities, local capacities by developing infrastructure where is needed, offering training and engaging in communication and advocacy activities. And at the same time, working with the various ministries of health to support country adoption and implementation activities, where we translate research into findings, translate research findings into policy, revise the various treatment guidelines, and engage in routine treatment of non-trial patients. So why is access important for us as DNDi? So initially, DNDi, as I mentioned, was formed to conduct clinical trials and deliver new treatments for patients. But then after being successful in doing so, we realized that our patients were still not receiving the required medication on time. And that's when we're now developing an access program, which has 4 key dimensions: the demand, the supply side, systemic obstacle, and then the financing issues. And what we try to do is address the various challenges that you're faced with insofar as these activities are concerned. And on the demand side, so far, what we've come to realize that there's a very long process to change policy once treatments have been recommended by various clinical research. So this delays the reach of the various treatments to the bedside of the patients. We have very weak health systems with not so skilled personnel. There's a very high turnover in our various health facilities. There's a lot of under-diagnostics as well as under-reporting because of weak systems, and also we lack effective prevention methods. On the supply side, as I mentioned earlier, there's very little incentive for manufacturers to venture into neglected patient research and development. So we have very few manufacturers for VL commodities. There's a very weak supply chain within the various supply chain management systems within the various countries that you work in. And the price of the commodities sometimes is too high that even the patients themselves are unable to afford, and even the various national programs are unable to prioritize the same. And systemic obstacles, which is the other dimension for access. The challenges we are faced with is a potential stigma associated with cutaneous leishmaniasis, mucocutaneous leishmaniasis, as well as PKDL, as these are diseases that are seen on the skin and then potentially causes stigma for the affected patient. There are cultural factors such as gender. I think the presenter just before me, I think, overemphasized on the issues around reproductive health and as well as access to contraception. So you realize that in certain cases, you may find that women of childbearing age need to take contraception to be able to access some of the medications that are for VL. And given the cultures that you're faced with in our region, where contraception sometimes is not very welcome in some communities, then that actually presents an obstacle to access the medications. Other social factors, such as geographical locations, which are very remote, making it very difficult for patients to access treatment, poverty that prevents the patients to even get transport, means of transport to access health facilities, insecurity that is quite rampant in our region, as well as population displacement are some of the systemic obstacles that we are faced with. And then on the financing side, we have very weak financing mechanisms. We are donor dependent, and it is not very clear sometimes who is paying for diagnostic and treatment. Currently, of late, up to recently, WHO has been the organization that has been procuring medication for VL for Eastern Africa using donor funding, but recently they mentioned that they've run out of funding as some of the big donors have pulled out. So as a result, we are faced with a very big challenge of not having adequate medication for VL. So we are forced to go back to the drawing board and hopefully be able to convince our governments to prioritize VL in their health budgets. So how do we turn research into access? And here I'm going to talk about the results dissemination process. So one of the things that we do is at the end of each clinical study, once the results have been published, we go back to the communities where we conducted the studies and present the results to them, whether they are positive or negative, so that they are aware what became of the clinical research that they participated in. We also give feedback to various stakeholders, notably policymakers, so as to influence policy change and revision of the treatment guidelines. And of course, public announcements at various forums such as conferences, events, and social media. And here is where we partner with the fraternity, with the media fraternity, to be able to let the world know on the results that we've achieved during our clinical research. So as I mentioned, the current first-line treatment for visceral leishmaniasis is sodium stibogluconate and paramomycin. And this is a study that was conducted between 2004 and 2010, and was conducted in 7 sites in 4 different countries. And the objective was to develop a cheaper and shorter treatment for visceral leishmaniasis in East Africa. Prior to that, the treatment for VL was a 30-day injection by SSG, which again is a toxic drug. So we are able to shorten the duration to 17 days by combining SSG and PM. And as such, we reduce the toxic levels of SSG that the patients would be exposed to. And in terms of access, what we did was we were able to revise the VL treatment guidelines in all the 4 countries, as well as also South Sudan. And then we managed to register paramomycin, as well as including it into essential drug list or essential medicines list, so that it is approved for use in the countries. We conducted an effectiveness study under field conditions just to see what are the challenges that we'll be faced with in real life. As you know, clinical trials is conducted in controlled environment. We trained health workers on the new treatment options across the region, so that they can be able to start implementation, and disseminated the results to the participating communities. So the current treatment that we are recommending out of the clinical trials that we held and were completed last year, again, it started in 2016 and ended in 2022 in the same 7 sites in 4 countries. And the objective was to compare the efficacy of paramomycin and miltefosine combination for 14 days with the current standard of care, which is a 17-day course of SSG-PM for the treatment of primary VL. Analysis is ongoing for some of the studies, and but for the main study, we've already presented the results for publication, and we hope that in the next 2 months we are able to have the study report published. At the same time, we've already started an accelerated process of policy change by engaging the various ministries of health, even as we wait for the publication, and hopefully we should be able to revise the guidelines for the treatment of visceral leishmaniasis in these countries, at least by some by the end of this year, and hopefully by next year we should be done in all the 4 countries. Our access activities for this specific treatment, which is being financed by the EDCTP, revolves around facilitating translation of evidence generated into revised national policies and revised WHO guidelines in the endemic areas. We also aim to strengthen the supply chain management and distribution planning so that the drugs, as and when they reach the national programs, are able to be distributed as fast as possible so that they can reach the patients when they need them. We also intend to catalyze widespread adoption of effective treatments and create the right conditions for scale-up by engaging in capacity building efforts to ensure that the health workers are ready to implement the new treatments. Of course, we'll also need to ensure that the new treatment, specifically paramomycin, is approved for use in the endemic countries, and this may entail including paramomycin in the essential medical medicines list, as well as probably even registering it in the region depending on the regulations per country. We also intend to support the various ministries of health to coordinate, build capacities of health workers, as well as in surveillance activities to ensure that data is captured and can be used for decision making, such as forecasting and as well as procurement of VL commodities. We also intend to conduct operational research to understand implementation challenges that are likely to be faced during the implementation of these new treatment. Primarily, we are looking at pastoralists who do not have physical abode, and probably sometimes we find that it's very difficult to reach them when they need the intervention. And lastly, is to engage in communication, advocacy, and social mobilization to ensure political ownership, as well as increase fundraising efforts. So what are the lessons learned over the years? So we came to realize that when we involve the main actors from the beginning, that is the various ministries of health, the regulators, other partners, during the conduct of clinical research, it ensures success of the same and again, acceptability during implementation. There's need also to work hand in hand with the various ministries of health and real national programs to ensure the success of the access programs. Currently, what we are doing is we are developing work plans in conjunction with the various ministries of health to ensure that we address the gaps that they are faced with at their various country levels, so that at the time of implementation, then we are actually supporting the strategies and the plans for the various ministries of health. Involvement of community groups is very key. One, for results dissemination, awareness creation, but also when we come back later to conduct clinical trials, then we become trusted partners in the fight against neglected diseases. There's need for coordination efforts amongst various partners, because we've realized that there's very little resources available for VL, and if we are implementing disjointed plans, then we are likely to not utilize the meager resources well. So already we are working with the key partners to ensure that we plan jointly and the activities are divided amongst the partners to ensure better utilization of resources. And lastly, and most importantly, is understanding the barriers to access before implementation. And as I mentioned, we look at access from the 4 main dimensions, and this really helps us in the success of our access program. And in conclusion, and speaking to you as a media, why do we think you are important towards this effort? We know that journalists can communicate the disease burden and the gaps of lack of tools, specifically diagnostics, as well as treatment for neglected patients. You as a media can amplify the voice of the neglected patient so that it can be able to reach the policy makers. Media also has an important role to play in dissemination of the results to the public and critical stakeholders. So, for example, when we publish the results, we expect that the media is going to help us to put this out there so that the public is aware about what we've done and the achievements we've been able to come up with. Media is also one of the most important sources of health information to the general public by disseminating information on a continuous basis, either through newspapers, through television, and all the other medium that are available to the general public. And lastly, you can help us to agitate for change, to ensure that there's political goodwill, and by communicating to reach the policymakers so that they can accelerate the process of changing policy to adopt the new effective treatments that we come up with. So we are looking yet again to continue working with the media fraternity, measure specifically that we've been working with for a long time, to continue with the fight for our neglected patients. Thank you very much. Questions?
Yeah. Thank you very much. This is really educative. If there is a question, please type them in chat. Thanks to Duta for being interactive in the chat. I see that you have responded to all the questions that was addressed to you. The question that I'm not addressed is about, okay, someone has asked if there is the office of DNDI in Ethiopia. Is there the office, Simon?
No, so in Africa, we only have 3 main offices: in Kenya, in DRC, and in South Africa. In Ethiopia, we have partners that we work with very closely, who are represented through the LEAP platform. One of our key partners in Ethiopia is Addis Ababa University, as well as Gonda University, and the Ministry of Health of Ethiopia.
Okay, thank you. If anyone has a question, please raise your hand or type your question in the chat. Or other one has asked about the presentation. Please share the presentation for their references in their emails. I think Agan has approved this. Okay. As we are waiting for any other question that can come up, I'm wondering why you've said that if there is a research that have been made on a given intervention or in any other topic, it's good to go back to the community, to the sample, to present the findings, the results. I'm wondering why most of researchers do not do that. They only publish, but they do not specifically present the findings to the community, to the sample. If it is not done, how is it important to go there back? What would help that particular community that they can miss if they are not presented back to them? Thank you.
Thank you for that question. I think one, I may not be able to speak on behalf of the other researchers who do not do that, but as DNDA, we've put it as best practice to always go back to the communities that we work with, because we know that these are the communities that we'll continue working with. So we need that goodwill. They need to understand that we are here to support them. Sometimes there are normally certain innuendos around clinical research that people misconstrue that researchers are doing funny things. So by us going back to the communities, we are proving that whatever we are doing is scientific, and we are able to provide the feedback to them. Secondly, it's also a requirement by the various ethics bodies, and as such, then we are also meeting the requirements of the regulators as well. Thank you. But I can see my colleague Cherinet would want to add on to that.
Yeah, sure. Yes.
Hello.
Yes, Cherinet, come in.
Okay. Regarding the dissemination of research findings to the community, it is one of our priorities. And in clinical trial, normally, it is one of even the requirements, just dissemination of the result to the community where the study is conducted is also a requirement, and we have it in our priorities. Thank you.
Okay, thank you so much. So, as you're speaking to the to science journalists, there are also some journalism students and other people that are not really that are new in journalism, but that wants to specialize in science reporting. I want to ask you which part of the reports, I know, as we all know, the research paper or research findings or the report contain a lot of information, but most of the time there are so many pages so that people cannot, journalists cannot read in when they are on their newsroom pressure. Which part of the reports can you recommend? I want you to guide our new science journalists, our students, journalism students, to guide them on how they should engage themselves in reporting about the research report. Thank you.
Yeah, thank you for that. Usually in all scientific reports, there's always a summary that summarizes everything about the report. But again, you may not be able to get the whole gist of the research from that summary. What we've always advocated for is that we work hand in hand with the journalists, because we understand that the areas we work with sometimes are a bit too technical, which may result in either misunderstanding or misreporting by journalists. So we normally take journalists through training on what we do and even the results of our clinical research, so that they can better understand it in their own way and be able to disseminate it in a way that the general public can be able to understand. So I would urge that the journalists work hand in hand with our team to be able to impart that knowledge to them.
Okay, thank you so much. As I cannot, I don't see, okay, I don't see more questions. I think that's the old hand, Shelinet. I don't see, as I don't see more questions, I want, okay, Musembi Sengu, sorry. Mr. Bolo, about a year ago, there was an outbreak of VL in the peripheral areas of Kitui County that border Tana River County in Kenya. Since camel herding pastoralists from northeast region of Kenya regularly sneak into the area to graze their camels. The local community believed that the camels brought with them the vector that bear the bacteria that cause VL. Was their assumption right or way off the mark?
Oh, okay. If I understood the question, probably the person is asking if a camel is a host for the parasite. As far as I know, there are only two known hosts for the parasite that causes leishmaniasis. So that's a human as well as dogs. So probably for this situation and something similar that has been seen in other areas where we have pastoralists, they move into the areas where VL is endemic and the human hosts are infected by the disease or the parasite, which then they take back to their communities. But again, I would probably let someone like Cherinet, who is one of our colleagues, speak to that as well.
Yes, they can go ahead.
Okay, thank you so much. Regarding camel being a reservoir for transmission of visceral leishmaniasis, I don't have clear information for now regarding the place where you referred to. But generally, camel is not known as a reservoir for transmission of visceral leishmaniasis. There are known reservoirs for leishmaniasis. For example, cutaneous leishmaniasis, which affects the skin, is transmitted from human to human as well as from animal. There is a reservoir called rocky hyrax, which transmits the disease, which acts as a reservoir for the transmission of the disease. For visceral leishmaniasis, canines are also known transmitter in some part of the region. But regarding the camel, I don't have clear evidence to share with you for now. Thank you.
Thank you. As we are wrapping this discussion up, I want to give every speaker a minute just to give us a final words in as we are going, we are close to the end of this discussion. Let's start with Simon. You have just a minute to give final words. I
can see Imable has raised his hand. Did you have a question? Do you want to take that question? Someone called Imable.
Yes. Can you hear me?
Yeah, I raised the hand. Yes.
Yes.
Yes, Imable.
Yeah, I was looking to lower it down, but now, as you said, one put my question to the presenter. He said that the neglected disease inflict severe health burden on the poorest people. So I need to know what type of neglected disease is the hardest to treat in Africa. Thank you. Hello.
Hello. That is a very interesting question. I may not be able to respond to that. Why? Because we have 20 neglected tropical diseases. and we are only working just a few of them. So I wouldn't be able to say which one is the hardest to treat unless anybody else in the forum has a clear answer to that. But as I mentioned, we have 20, WHO lists 20 neglected tropical diseases. So probably until you work in all of them is when you can be able to know which one is the most difficult to treat. Thank you.
Simon, this is the captain. This is the captain speaking. Yes. Simon, basically, I think what that journalists would like to know is that in terms of the burden of the neglected diseases, where are we? One would be in terms of the one that mostly affect many people and not much attention has been given to it. What kind of budgets are we talking about here? What kind of interventions are we talking about? I think basically that is what the writer would want, maybe not ranking them.
Okay. So as DNDI and specifically in this region, so here one of the most, there are three key neglected diseases that we started working on. They're called the kinetoplastids. So one is visceral leishmaniasis that I've just talked about. The other one is human African trypanosomiasis, which is in the Central African region, and the last one is the Chagas disease, which is in the Latin American region. Probably I'll be more familiar with the human African trypanosomiasis and VL. So we've made very significant progress on human African trypanosomiasis. We have a wonder drug right now and actually just developing another one that will be able to treat human African trypanosomiasis just with one single pill. So that will obviously be very important towards the elimination strategy, which we are seeing for human African trypanosomiasis is in the horizon. Now for VL is where we have a bit of complications. Why? Because up to now we are still using injection drugs to treat VL in this part of the region. And secondly, so if it's injection, then it means patients must be hospitalized to be effectively treated, even though, like I've mentioned, we have just managed to recommend a new treatment, which is yet to be implemented in the region. So given the challenges that you're faced with, two key challenges. One is on the diagnostic, because to be able to treat, you need to diagnose the disease. So prior to this, we used to have very invasive diagnostic methodologies for VL, where a clinician would either get into the spleen or into the bone marrow to be able to get a biopsy and look it up in the microscope to confirm that the patient is infected by a VL parasite. Then we were able to recommend a new rapid diagnostic treatment that using just a prick of blood, you are able to confirm diagnosis. Luckily, out of the 5 countries, 4 are implementing rapid diagnostic test as a means for confirmatory diagnosis for VL. Uganda recently just is moving away from invasive procedures to adopt rapid diagnostic as the main methodology for diagnosing VL. Now, what you're faced with is that we had only one manufacturer called Biorad, who was producing the kits, the test kits for rapid diagnostics. Unfortunately, a new regulation came up in the EU that made it impossible for them to continue manufacturing. And as such, they are pulling out from manufacturing these diagnostics for VL. Their last production is in May, and we have just collaborated with them, WHO and other partners, to be able to make our final orders that will be able to last us until mid next year. Luckily, they have been willing and have started the process of a technology transfer to another another company called Mologic Limited, who hopefully are going to start production by the end of this year. Now, as I mentioned, on the treatment side, on the drugs, so we have WHO who have been doing pooling of quantities and pooling of finances to be able to procure. Why? Because the numbers at country levels are not sufficient for any manufacturer to be able to produce one batch. So WHO has been helping with that by pooling the quantities from the various countries, but also at the same time pooling resources from various donors. Unfortunately, donors, for whatever reason, started pulling out, and WHO currently, in the next few months, will not have funding to be able to continue purchasing drugs for visceral leishmaniasis. So these are the kind of challenges that we are faced with that makes it very difficult for patients to be able to get treatment. Now, on top of these challenges, there are a million other challenges internally at every country, which I talked about, one being stock management. So you realize that the supply chain management, it is dependent on each and every country. So for Kenya, for example, we have a devolved government where all the supplies come to a central body and then they're distributed to the various county pharmacies. Then the county pharmacies are now how to distribute them to the various 41 different health facilities that treat visceral leishmaniasis in Kenya. Because of the challenges of supply chain management, sometimes you realize that the drugs are delayed to be submitted to the health facilities that require them, and as a result, sometimes end up expiring. So challenges coming all the way from the supply side, all the way down to the country level, makes it very difficult for VL patients to access treatment. Thank you.
Thank
that
you.
Was clear?
Yes, I think Agan, that's clear. Thank you so much. Thank you so much, Simon. If we are still together with all the speakers of our sessions, our afternoon session today, you want to give you a minute to give us a wrap-up words or for your respective topics that you have tackled. As you have the mic, Simon, we can start from you and give us just a word, a wrap-up word on this issue of turning research results into action. Thank you.
Thank you very much, Christoph. My last word is that we have patients who are disproportionately affected by this disease. We have a system that does not provide incentive to manufacturers to come up with a new treatment for neglected patients. We have governments who do not prioritize this disease that is affecting the patient, and if left untreated is fatal. Our ask to you as a media fraternity is to partner with us to be able to be the voice of the patient, to amplify their voice so that they can be heard. The neglect can be dealt with so that they can be able to have the treatment that they need as fast as is possible. DNDI and its partners are working very hard to try and come up with new treatments. The current treatments, even though are working, are not adequate. Some of them are toxic, as is mentioned, but we have no choice but to continue giving them to the patients. We have a portfolio of new chemical entities which would hopefully result into oral drugs that we want to bring for the treatment of visceral leishmaniasis. We hope that you can work together to support the effort so that more resources can be allocated, there's political goodwill, and patients' voices can be heard. Thank you very much.
Thank you, Simon. Thank you very much. Then Duta, have the mic, please.
My last comments are, as journalists, as individuals, as communicators, as stakeholders at different levels, we must destigmatize reproductive health. and report it correctly to encourage conversations, policies, and decision-making at all levels. As DSW, we are at the forefront of advocating for the availability of information and services, because these go a long way to enhance the human right that is reproductive health, and also to make sure that we've reduced unintended pregnancies, we've reduced maternal deaths, and we've reduced HIV and STI infections. Thank you.
Thank you very much. The next is Mugo. Oh, I think he dropped off. Then Dr. Evelyn, the mic is yours. You can evenly comment or
Dr. Evelyn left, but there is something that she requested me to address. There's a question that Samuel Doe asked, and Samuel was saying this, that I only get comments or interviews with the Ministry of Health and the AMR experts during the annual AMR week. After that week, getting someone for AMR comment or interview from MOH has been very elusive. And this is what Evelyn has to say. And maybe I wanted to go into our Hansard, that we have a process of engaging Ministry of Health officers through our Public Relations Office. Let members understand that public servants need clearance for interviews and comments. And then she also told me that them as experts, they're very much committed to speaking to journalists, and they are just requesting that let us build trust. So I think that is what Evelyn would have said had she, been saying a parting shot. Back to you, Christoph.
Thank you so much, Captain. Thank you very much for that intervention and being there for Dr. Evelyn. I think we are at the end of our session of this afternoon. I hand over back the mic to Agan. Thank you, Agan, for giving me all the mics today. I think we have learned a lot from our eminent speakers. They gave us really important information that we can use in our daily news gathering for our audiences. Thank you, everyone. Thank you. Thank you to Dr. Evelyn. Thanks to Kariuki Mugo. Thanks to Wawelu. Thanks to Simon. Then I hand back the mics to Agan. Thank you and have a good evening. Bye.
Thank you very much, Christoph Hitayezu from Kigali. We hope that Kigali is doing well, and thank you very much for steering us through that afternoon session. I'm seeing a hand that is up. I think that is Alice. Alice, you want to voice something? Please go ahead.
Yes, I'd like to say just short remarks. So thank you so much for everyone who's taken into this day. It has been amazing. It has been so interactive, so engaging. Thank you so much for everyone who's tweeted, who's been engaging with us on social media using the hashtag that we shared. But I would just like to say we have put together all the presentations that have been made here today. We have done it in a short recap way that is accessible via WhatsApp. If you look on the chat box, you will see a link that is saying click here to receive day one recap. If you click that link, it will take you to WhatsApp with the word recap already texted on a chat box. If you click send, you will receive a PDF version of a summary of everything that was discussed here today, including the links to the available resources. Some of them we realize we don't already have, but we will be uploading them as we go. So thank you once more, Agan, for this opportunity just to bring this to your attention. Feel free to use our chatbot for any other thing, but if you send the word recap to WhatsApp, you will receive that PDF on your WhatsApp, and you should be able to follow the links to the different presentations that the different speakers have used. Thank you, everyone, and see you tomorrow.
All right, so thanks. I think basically one of the things that has been coming up now and again, will I get the presentations? Will I get the presentations? I hope that now your concern is addressed and that you are able to do stories. We have had about 10 speakers for today, and I think that we've not wasted your time. So that basically means that it's been a good day, and that we are able to get stories from you as well. I would also want to thank the social media team for a job well done. I would also want to say that in the morning I talked about the COP27. So I want us to start thinking about COP27. Those who will be interested in going to a small city in what we call in Egypt, please be on the lookout for those goodies. Now I just want to share tomorrow's program for those who I just can't see it, but I think that is there anybody who can? If you give me like 2 to 3 minutes, I'll get for you the program for tomorrow. I just want to share it here, and again, maybe Alice, you can pick tomorrow's program and share it with everyone the way you've shared. You can put it in a link and then share it with everyone. So just give me a few minutes. Now, Simon, are you still on this call? I had a special message for you.
Yes, I'm still here.
Yeah, so Simon, I think that our relationship, the relationship between MESHA and DNDI has come of age. We have been doing this thing for over 10 years, if you remember. And so I think it's high time that we came up with an MOU so that we just don't become partners during the conference. That is a challenge that I'm throwing to you. I hope that your director is on this call and your colleagues, that the way we have related, it is important that now we go the MOU way and ensure that some of these issues do not become, like event-based, but we look at what we can do within the 12 months in a year. So Simon, I know that you are going to be a good bearer of that message, and that it's basically going to work for all of us, especially for the two organizations, so that we can meet. Okay, I see. I hope that is Monique. Monique's hand up. So Monique, the floor is yours.
Thank you very much, Dan. We have been having this relationship with you for over 10 years now, and really we are supporting each other and want this to continue. So yes, we're very supportive of your suggestions.
Thank
you. I'd like to also thank Simon for an excellent presentation, and the programs today really other presenters as well. I was able to listen to a few of them, so the quality is high and the people are engaging, and this is what we want. And especially for us who work in neglected diseases, neglected patients, you are our voice and their voice, and very important interaction. So thank you. And yes, we wish to commit further to working with you.
Okay, thank you. That is
sorry about my background. I'm also advertising the World Dish 7, which is coming in Colombia. I was a speaker, so I think it remained. So it's going to be there in August.
Yes, so that is Dr. Monique Wasuna, who is the head of DNDI. And Monique, something that they may not tell you, but let me tell you this afternoon is that I compare you to the late Franco, Luambo Macchiadi, TPOK jazz. Franco brought in these stars, and all of them were producing music and singing. And like my friend Kofi Olomide, who is always at the front, I know that you are always there, even when we don't see your face. And we know that all the email that we send to Lynette and to Simon, you read them. And I think that is the kind of support that would make DNDI go a long way. And not just DNDI, those who work in the space of science. So congratulations for a job that I know you know how to do best. We have always worked with your officers, even when we don't see you. And when we see them, we know that this is Dr. Monique who is with us. So thank you very much. And that MOU, my team is going to follow it up with you so that we see how we can ensure that these issues that we are talking about remain in the conversation.
Thank you very much. Much appreciated.
Thank you. Yeah, so now over to the program. Somebody to have a look at, oh yes. Huh? Okay, I'm told that the program has been shared. So I think that is taken care of. So tomorrow, what time do we start? So tomorrow we start at 9:00 a.m. Kenyan time. Please adjust your clock so that it is 9 a.m. Kenyan time. Thank you very much to the interpreters. I think you've done a good job. I was not able to tune in for the French. I will do so tomorrow, but I think the job was well done because I didn't see any complaints from my Francophone friends. So unless somebody has got any housekeeping issue to talk about, it's been a nice day. We finished at 5 p.m. on the dot. Tomorrow we are on it again. And we started at 80, we have ended at around 80, and we went up to 100. So that's a very good, very, very good number. So bye-bye for now, and have a great evening and good night.
Thank you, bye.
Goodbye.
So now we can make all the noise that we were itching to make. I allow you to make them. You can turn on your video so that we see all of you. Oh.
Goodbye, Captain.
Goodbye.
Hello, Captain.
Hi. Collins, how are you?
I'm fine, sir.
You kept on coming in and out, so you will have to stop those bad manners.
Duty calls. Unajua me, I'm a driver of 2 vehicles.
Okay.
One called Salma, the other one called Amina.
Okay. Good job.
Thank you.
Okay. See you tomorrow.
Good evening, Captain.
Hey, JB, yourself, how are you?
Fine.
Oh, great. I can see my friend Ida also dropped in. Ida, nice to see you.
Bye. See you tomorrow.
See you tomorrow, JB.
Thank you, Agan. Thank you. This is really, truly amazing, Agan. Gosh.
Thank
Fantastic.
you.
Yeah, I mean, I'm not surprised.
Yeah.
I'm happy to see it's the usual standard from Mesha. It's fantastic.
Thank you. Tomorrow will be another great day and excellent day. We look forward to it. And we welcome you back, Ida, for tomorrow.
Of course, tomorrow I can be here for longer times. Thank you.
Okay, welcome. Okay, bye-bye. Even if we end it now, it's okay. Over to you, John, to end the meeting for us.
Bye.
Bye-bye.